Why are things arranged the way they are?
This diffusion across a membrane, there are
No, that is membrane, that is bubble. That is one is gas exchange across a membrane. But the circuit design, how is it determined?
Temperature control also integrated.
Huh?
Temperature cooling systems also.
No, both of them have temperature control systems. But the essential difference, if you know the difference, then you will be able to tell the thing. You're wrong? Write the full circuit, no, don't look at my face. I don't have a beautiful face. Draw the entire circuit. A whole circuit, right from patient to arterial line to like that, this side venous line to oxygenate, whatever, whichever way it goes, I'm not going to tell. What is the difference? Is primarily, you know, you don't know. If you don't know, you tell me you don't know. You know, you don't know. Yes, no. Honestly tell you don't know. If you keep quiet, it means that you know. You don't know. The thing is that a membrane oxygenator requires pressure to drive the gas exchange, because there is a gradient across it. Whereas a bubble oxygenator, air is lighter than water, so gravity just goes up and oxygenates. So you need the pump in a membrane oxygenator before, whereas the bubble oxygenator can just oxygenate, it doesn't require this thing. Now the thing is that the other thing that is there is, now bubble oxygenator, what is going to happen? It is going to bubble a column of this thing. Now you have to debubble it, deform it, and settle it. So once you are passing it through and bubbling it, what is the reservoir that will be there? I pass it, I bubble it, and it settles, the bubble settles. So what kind of reservoir is there in a bubble oxygenator? It is a, no, it has to be open, but is it red? What will be the color of the blood in the reservoir? Red or? It will be red. So the reservoir is arterial. So now the problem is that if I get too much of blood coming from the venous side, from the suckers and other things, and I have a lot of blue blood coming up there, and if I dump it into the reservoir, what will happen? It's an arterial reservoir which is going to get dense, so it has to be filtered, number one. Okay, I put a filter. But the problem is if I have a lot of blue blood coming in, it will again cause the saturation to fall. So I have to have a way of controlling it and sending it to the bubbling chamber. So you have a what is called as a cardiotomy reservoir. So unlike a membrane oxygenator, you have to have a cardiotomy reservoir, and you have to have a the blood, the suckers go to a cardiotomy reservoir and goes into the oxygenating area after filtration. Then there is a, the venous blood goes and is immediately bubbled, filtered, bubbled, and it goes into the, become in the arterial reservoir, and then it is then pumped. Whereas in a membrane oxygenator, we have all seen what happens. SVC, IVC blood, he is drawing it forever. SVC, IVC blood goes to the, is there a deforming chamber in a membrane oxygenator? There is no foam occurring there. What you have is, you rotate it and then it goes through a series of filters. What are the filters that are used in oxygenator? How are they classified? You all should know this, yeah? Something black will be there and then something white is there. Huh? You all have to read about CBB. It obviously means you have no zilch about CBB. There are two types of filters. There are depth filters and screen filters. Depth filters are like sponge. I would suggest that you go, take one oxygenator, go to the anatomy department. They have that thing to saw the cadaver, no? And ask the technician to saw the oxygenator, and then you will see the reservoir and the oxygenator, and you will be able to see the content. So there is a band saw, no? It cuts the skull in anatomy department. Go there and take it and cut it. So the screen oxygenators are, I mean, unfortunately I can't keep on talking about it further because it's, but remember, there are screen oxygenator, depth oxygenator. Find out what is channeling in a, what is channeling, and then find out how the efficacy of these are measured and how are they used. what is the advantage of depth filter and a screen filter, and how do you improve the efficacy of each of these. So come. Now there is another thing that is commonly asked is muff and cuff. You know what muff is and what is cuff is, what is duff, what is rebuff? Silence of the lambs. Yes, Clarice? Huh? Conventional ultrafiltration and MF is? Duff is? Duff is? Don't tell it as duffers. Dilutional ultrafiltration. And then what is Z-buff? What is Z-buff? My sincere suggestion to all of you is there are textbooks on cardiopulmonary bypass. Have you heard of Gravely and Utley? Then Kenneth Taylor, Ionesco, and what is that? What's the name? Christina Mora. Please open those books. Their books are there. You should not keep it under your pillow and expect it to have transcranial imbibition. What is now? Can anyone draw? You've heard of cuff and muff, right? Yes or no? Now, if you have heard of cuff and muff, can you tell me can someone come and draw the circuit of cuff and what is muff? You do not know. Okay. Cuff is that you take the blood from the patient, from the reservoir or from the patient, and then you filter it and you pass it back to the patient. What are you filtering there? You are filtering, and it is done during cardiopulmonary bypass. And what are you filtering there? Not the patient. You are filtering the reservoir. So if you are not having enough volume and you do aggressive conventional ultrafiltration where the reservoir volume is being passed to the filter, fluid and other things are and toxic metabolites are extracted, and then it is connected and it is fed back into the reservoir. So what happens is, and then that is picked up by the membrane, by the pump and pumped. So this actually filters the reservoir, it does not filter the patient. So what will happen? Level can fall. Now if you want to have a constant, if you have a volume overloaded patient, the levels will fall and it's not much of a problem. We will be dealing with it actually. We have overflowing oxygenator and things like that. But the other side of the story, but then it does not actually act on the patient. So if I have a low volume, I can keep on adding volume, and this is called as zero balance ultrafiltration. If I am having a very dry patient or I am extracting more, I can add fluid to the patient. If I have a polycythemic patient, I can add fluid and plasma and other things, and that's called as dilutional ultrafiltration. So there are various things which can be done. So be aware, please open the book and read. And you must know Elliott and Naik, very famous paper by Elliott and Naik, and you are expected to read that paper. Incidentally, Elliott is still alive and he is not doing cardiac surgery, but he is doing thoracic surgery in UK. And he was in Great Ormond Street. Very famous paper by Elliott and Naik. Okay, now sir, shall we start with the... please read up about these things. You will cut a very sorry figure if you don't know these things. Now, can you put that thing, please? No, make it run. Yeah, ready. I want it on the screen, no? There's no use having it for me. So now, accidents are created, it's not made. Now, all of you have, how many of you have heard of this new controversy about the lot of Galata which has taken racist undertones? That's a different story. About the valve which has been implanted upside down in Osho. That is, you know what Osho? It's a very famous center where Albert Starr worked in. And the pediatric unit is called as Osho. And there in Osho, a valve was actually supposed to have been implanted in the pulmonary position is what I've heard. and they have implanted it upside down, and what has happened is, what will happen if a valve is implanted upside down? What is the finding that you get? What is the classic finding when you have a valve which is implanted in the inverted position? See, come on, now final year students should tell this. This is a standard Viva question. What will happen when you try to come off cardiopulmonary bypass? What? Distension, and what else? If I do a tricuspid valve replacement, there won't be distension. But what else will happen? What will be the amount of ejections? 0 ejections. So there are some classic conditions which we ask. I do a ASD, I try to come off bypass, and I get 0 ejections. What screw up has happened? 0 ejections. Huh? A TAPVC. So a TAPVC has been the same. Now I close a VSD and I have 0 ejections. It's a double chamber right ventricle, and you have gone and closed off, or you have taken an outlet VSD, and instead of closing the thing, you have closed off the pulmonary artery. Okay, then people have done it. Then if I have, I've done an AVR or an MVR and I get 0 ejections. One is said upside down, that's yes. But more commonly, I know that I have not implanted it upside down. Huh? Speak loudly, give the mic, no? Huh? What inadequate plegia? Even if inadequate plegia, if the heart is beating, at least one tukku, 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 tukku will come. I am telling 0 ejections. Unless the heart is deadened in rigor mortis. What is rigor mortis of the heart called? Intraoperative rigor mortis of the heart called? Stone heart. So now, just took. Thank you for coming a little bit. You can come. You could have come a little later, my boys. मेरे बच्चा नहीं है. Yeah. What is it? It is a valve stuck in closed position. If you have a valve which has got stuck in the closed position, there will be no way blood can come out. It's not partially open, partially closed. It has happened. In fact, I have encountered once when that's why we always say you have to be very careful about that thing. The valve was stuck in closed position because one suture had intercepted and gone in, and it had got stuck. And I was telling, this valve is stuck in closed position. We have to go back, and then I was junior at that time, and people, and then ultimately we had opened the aorta and found that what it was. But then you remember that these are the things, and it is important that you don't continue to be. What is your response to these things? What will be the response if you have a valve stuck in closed position? You immediately go back on full cardiopulmonary bypass, because you are now going to ram blood. The heart is trying to eject, and it is going to cause distension injury to whatever. If it is mitral valve, it's going to make the patient is going to be in florid pulmonary edema. If it is this thing to aortic valve, your ventricle is going to go damar, all those things. So now I will tell you one question. The valve was stuck in this thing, and what was the error that was made? They could not come off cardiopulmonary bypass, and they went on ECMO. Now the first question that when I read this was, what was being done by the cardiac anesthesiologist, the cardiologist, the ECMO team, everything. One of the most important principles when you initiate ECMO is that you should have corrected all intracardiac this thing, and you are only waiting for ventricular recovery. So a transesophageal echo should have been done. They should have been checking. Again, the challenge to put and see to see what is the thing. A valve not moving. So it was not just that the surgeon goofed up. The surgeon goofed up, the assistant goofed up, the nurse goofed up, everybody. So, but at the end of the day, captain of the ship, you are always blamed. But there was a series of mistakes, and this series of mistakes are what are called, I'll be showing it to you. And I'm just telling this example is what is called as the Swiss cheese hole lining up. You have seen Swiss cheese with multiple holes. You can't see, if I put one piece of cheese, another piece of cheese and another piece of cheese, the holes will not match. But if I make the holes match, I can see through, and that's called as the Swiss cheese theory. Most of what I will be talking is from aviation industry, because aviation industry has got one of the safest, it's more safe to be in a plane than crossing the road here. I'm not joking. In fact, somebody was telling I'll go for a run. I said, do you know what is the highest cause of death of doctors when they attend conferences? Do you know what is the highest cause of death of doctors in conferences? Anyone knows? It is the doctors going for a jog and getting hit by a vehicle because they are in an unfamiliar area. You go there, then the worst is if Indians go to some other country like US where the traffic is ulta, you will be looking, where do we look? We look this side, the cars will be coming from that side, okay? So actually the highest cause of mortality there is, so it's actually even attending a conference and going for a job has got a higher mortality than the aviation industry. So most of the lessons are from aviation industry. And I'm not joking, these are hardcore statistics available. So accidents are created. Now, we will be, actually I usually do this with the heart-lung machine and this thing, but it usually takes 2 to 3 hours. There is a CPB thing which I have put online. Basically the same thing has been put for decades on YouTube. You can see it in my channel. So now, the thing about an accident is, I will ask all our senior faculty here, how many intraoperative dissections have you seen in your life? How many have you seen? 1. How many have you seen? 1. How many have you seen? 1. Sir, how many have you seen? 0. I have seen total 3 intraoperative dissections over 35 years. So now, it's a low probability event. Now, the time to learn how to deal with an intraoperative dissection is not when the dissection occurs. But when can you learn? You very likely may have passed 3 or 5 or 6 years of whatever is your course without seeing a single intraoperative dissection. See, in 35 years of my being in cardiac surgery, I have only seen 3. He has seen one, they have seen, and around 15, 20 years of their experience. So what I'm trying to tell is, Dr. Shukla has seen 1 in how many years of that? 37 years of experience. So now it's very the thing. So now low probability events, you cannot expect to see them, but you need to be prepared for them. And so repeated practice is required, and there is a thing called as reaction time. The time taken to recognize that a problem has occurred and to react to it. What was the reaction time for that event which occurred? That reaction time was not hours, not minutes, not hours. The valve was implanted, but it was finally recognized when the patient was shifted on ECMO to a transplant center. Osho was not a so you can imagine, people are just yelling at the surgeon did this, surgeon did. Yes, surgeon was one part of the equation, but there was a series of screw-ups which has happened and nobody has recognized this, and that is the problem. So when we deal with these things, so for example, when I asked you what happens when, what the mind does not know, the eye will not hear, the ear will not hear, whatever. All your senses will not work. So now you need to this. So you need to practice. And practicing by the team allows coordinated efforts, and standard protocols allow coordinated responses. Now I will show you this very, very famous this thing, and that's this. This is a very famous this thing. This is the landing. You all know, you have heard that Sully landing on the Hudson. Now all of you have come in. Most of you have come in a plane, right? All of you have travelled in a this. In the olden days, it was not necessarily that we all flew in planes, but now all of you have. All of you have opened. There is that safety brochure inside the plane, and then they have all shown the evacuation on a water. how many water landings do you think has occurred in aviation history? Huh? There are only 3 water landings which have actually happened. I mean accidental, I'm not talking of a seaplane landing on sea, but there have been only 3. But every time we put it. Now, can you tell me the beauty of this thing is, I will tell you something which you have never thought of. This plane is in the water. Now, what do they tell? Only evacuate when the captain tells you and the door is open, right? But there is something else that is done specifically in a water landing. Can you see what has happened? There are people on the wings on both sides. The plane is balanced. So one of the things that this thing is, what will happen? People will panic and they will come out. But it is the responsibility of the captain to actually see that. But did you think that they had to do this when you saw water landing? Did any one of you think about it? No. But in the protocol, they have to see that this thing, what is it called? The air hostesses and the stewards are expected to do this, because I used to run CPR classes for air hostesses and other things at one time, and at that time I used to teach these things, and I used to sit sometimes in their classes. This is specifically taught. Okay, it maybe in the life of an air hostess she may never have ever get to see or execute this, but it is expected to be done. Now, I hope this plays. Can you make it play, please? Can you make it play? Oh, no. Can you make this? Yeah, please. I am hearing it. They should hear it. Anyway, can you people hear it? Okay, connect it. 1 minute, please. Sorry. Anyway, what I am trying to tell is, this is the actual recording of the conversation which is going on. Can you see here? I don't know, he's not put it yet, but can you see? This is the same plane which is going to land on the Hudson, and this is the actual this thing. Now, there are 2 terms which are used in aviation, which is Roger and Wilco. Now, actually, it's not Roger which is commonly used, it is actually Wilco which is commonly used. Wilco means you will have to repeat what is said. So I don't know whether you have seen. Go on bypass. What will the perfusionist say? I will go on bypass, or going on bypass. Why this conversation is repeated? In aviation rules.
Stand by. I tell you what, for 594, yeah, why don't we just set us up in a different pattern here for the
you may not be able to hear it very well, but whatever he is telling,
go around 5 runway heading,
he is repeating whatever. Pilot says something, he says the same. ATC says something, pilot will repeat and say Roger or Wilco or whatever that he says. Now, what does it mean? For example, that is something which I always teach perfusionists, is that if you don't answer back, if the surgeon does not answer back, it means what? He has not heard. So don't get irritated with the perfusionist when the perfusionist says, my level is falling, and you are operating. My level is falling, sir. Why are you disturbing me? Don't never do that. Level is falling. Yes, level is falling. You are supposed to repeat it back. And then I will see, and you adjust with it. So or he says high line pressure, sir. You have to repeat. Yes, I hear you. Line pressure high, but you are supposed to keep repeating it. What happens is, if something is not repeated, it is not heard. That is to ensure this thing. So this is one of the most important things that happen. And I will give you another famous thing. This is a very famous thing. Can you please tell? I don't know whether you people will recognize this. This is the Houston, this thing, Challenger has gone up in the air, and then, please play. He says, Houston, comm check, comm check. That is, comm check means communication
Columbia,
check.
Houston, UHF, comm check.
No answer?
Columbia, Houston, UHF, comm check.
He's saying comm check, Houston. whatever the number of the flight, STS, whatever, com check. No answer. This is the time when they were not getting the answer that they realized, see, those people are inside that room, they are having telemetry and other things, but they are not able to get any answer. This means to say that there is something really wrong. Why? All these things are ensured that day. So here there was something major going wrong. What had happened? Challenger had actually exploded. That's why when he was saying Houston, com check, and he keeps telling Houston, for example, when this thing, Eagle has landed. Yes, and he repeats, Eagle has landed. Confirmed Eagle has landed. Eagle has landed is, no? The moon landing. So, what this thing is that what you can't be like this. I don't hear this thing. If you cannot see, if you cannot hear, and if you cannot communicate, there is going to be errors. Now I'm going to ask you, okay, current goes off, battery is down. What do you do? The current goes off. Modern day, when I was a student, we didn't have battery backup in this thing. So what is done? Yeah, like this. Which direction does the hand cranking occur? Yeah. Okay. Which direction is the hand cranking? So, what is the most dangerous part of if the pump goes off is actually the patient can exsanguinate. So, what should the perfusionist and you do if the thing comes off? You have to clamp the venous line. Otherwise, the patient can exsanguinate. Okay. When the pump stops here, it continues to drain. Please remember that. And hand cranking is very effective. And this is actually something which I actually make my perfusionist trainees do. One of the things in the exam is that we do in the simulation is we make them hand crank, and we'll be just talking. One student will be made to assemble the pump, one is saying blah blah blah, and one student is saying. So I keep telling that you tell your mother, that rubgundu, that stone, you practice with that. I just joke to them, make your chutney for your mother. But a perfusionist will be able to do practically for at least 15 minutes, and then another team is saying. Now this is coming to that, we will be coming to this, that a single person is going to be should be able to do it for 15, and we actually make them practice it. Okay. Now this is another important thing. See, many people, I told you about bubble oxygenator. This is a bubble oxygenator, and this is a movie called Suffer. This movie was actually shot in KEM hospital. And I'm sorry to say, what is this, Sharmila Tagore is the heroine of this movie. This was actually shot in KEM hospital. You can see the polystyrene oxygenator, and this is the bar which is used to raise and lower the oxygenator. Then there is a cylinder. This is called as the Rick Quisquard oxygenator, which was marketed as polystyrene. When I was a student, we were using this oxygenator. This was one of the forms of a bubble oxygenator. Now the thing was, I have put an arrow here. Now the rule was that we always had to have a torch was supposed to be hung here. Can you see there? It was always, in KEM it was a rule that a torch had to be always hung here. There had to be an oxygen cylinder and a standby oxygen cylinder. We didn't have piped gas at that time when I was a student. So now what happened is, they wanted to take the thing for shooting the movie. This is a very famous thing that happened. So what happened is, see now this scene is what, now imagine if a torch is kept here, it will block the view. So one of the fellows who was shooting removed the torch. Now for bad luck that day, the current went off. The current went off, and in KEM what happened, because in those times ACs were not very good, all the windows and other things used to be painted black. So when the current went off, it was pitch black. Pitch black, and nobody could see the reservoir level. Then people ran to get the thing. Nobody could even see the knob. It was, I mean, you should see, because it used to be pitch black. Nothing could be seen. And so what happened is the oxygenator emptied and the patient, by the time they realized that the patient is exsanguinated and they think that thing, they tried doing all sorts of stuff, but this patient in this movie actually died. And that's a sober reality, this thing. And after that, what Dr. G.B. Parulkar would do, and in fact even in Jaideva we were doing it before, was that we used to chain the torch to the pump. Today now they have all on their mobile phones, so I am not very particular, but in previously around 20 and odd years back, we used to have an emergency light, which used, what used to happen, people used to rob the emergency light. So we had to chain the emergency light there. And in fact my perfusionist, Mr. Prasad, had got torches which you could hand crank and get light for that reason. So these are all very important things, and just out of historical this is how the CPB circuit was looking like. This is actually from the movie Suffer, from that patient. Now you can see here, I was actually, when I was a student, can you see here, this is Dr. P.K. Sen's actually, the open heart machine which Dr. P.K. Sen was actually using at that time. It was made from a car axle, so you can see it is on the side. And can you see something funny? The tubings were all, you used to use red rubber tubings mainly because the tubings would crack otherwise. You can see here, this is for historical reasons, this is called, this thing which you see on top is this. It is called as a Brown-Harrison heat exchanger, and that was the heat exchanger which was being used. And here I was just talking to you about a, can you go back? This is the cardiotomy reservoir for the bubble oxygenator which was being used. Okay, I just put it up so that you people can have this thing. You can go to the scene in the movie in Suffer, it is available on YouTube, and you can actually see the scene and you can see how bubble oxygenator are the thing. So now don't think that hand cranking is just not studied. They have actually done extensive studies about the skill and the management and the training, and we actually implemented this when we were training our students, perfusionists. Now, can you run this please? Can you run this? Please run it. When I ask you to run something, please run it. Because, no, back. Please run that video. So we are actually showing you a simulation.
We have always maintained a protocol of keeping a torch handy on the pump. So in case if there is any power supply off or anything, we can immediately switch on the torch. So today, there's another scenario that we are going to talk about is when the power supply, the main power supply is completely cut off. So what happens is, now you can see that the pump is running on battery. But sometimes in worst case scenario, what happens is the battery also gets drained. So in such a case, what we do is we need to hand crank it. So this is the hand crank that we are using, and the direction of the hand crank should always be in an anti-clockwise direction.
It is anti-clockwise.
We have to keep in mind the levels of the oxygenator and maintain a proper pressure also. In case we are unable to see, what we can do is see the monitor. What we can do is we can see the dial.
Okay. Now we will, so that's an example of training that is going. This is a training session which is going on, where we actually make the student hand crank for, and I run this, I used to run them regularly, I tell them to run it. Once a year I used to run a wet lab course for our perfusionists when I was previously. I don't know now whether the juniors are doing it, but it is expected to be done. Now, I am going to ask you this situation. Pump is not ready and patient is arrested. Students have to talk. This is for you. Pump is not ready and patient is arrested. Huh? Pick up another patient. Huh? Give CPR. But then before you give CPR, think. I told you, the holes have to align. So what is the first thing that you should do? Which are the patients which could potentially arrest?
Aortic stenosis.
Huh?
Yes.
Can you please hand them
left main and severe AS.
Left main, severe AS, mitral stenosis could also arrest. Any stenotic lesion any stenoticulation, be it congenital, valvar, anything, and stenosis in the coronary vein, which is the left main. In fact, today you don't see so many left main arrests, but it was quite common when I was a student and a young consultant for left mains to crash and arrest and this thing. So now, what is the, so pre-warned is pre-armed. So now you have a left main or this thing. So what are the things that you will do if you have a left main?
Pump to be ready.
Huh?
Pump to be ready. Keep ready. Pump.
One, keep the pump ready.
And
Number two,
one surgeon keep to be scrubbed.
3, nurse should be scrubbed.
Yes, sir.
Table should be put ready. Sternotomy instruments, everything should be ready to go on cardiopulmonary bypass. 4, anesthesiologist should have a very smooth induction. If the patient is having angina, you will have that's not the time to run for your IABP. Huh? You have to keep these things. So you might have to have nitroglycerin going, and during induction you should not have hypertension, keep the patient pre-medicated properly. So you see, there's a series of things which have to be done to prevent it. First step is try to prevent such a thing happen. Then once it occurs, anticipate. Now once it occurs, you start CPR, and then what is the game? What is the chance of a patient with a severe aortic stenosis or this thing? In modern day this thing, what could you do in 2026 that you could probably not do so easily when I was a student? To establish cardiopulmonary bypass very quickly
CO2
in
prime.
2026.
CO2 prime, sir.
Huh? CO2 priming is priming of the oxygenator. I'm telling you what the perfusionist does is one set of things. What you are going to do, how can you establish in 2026 very quickly cardiopulmonary bypass? You could go percutaneously. Today there are percutaneous cannulas. So for that, what should you have? You should have placed your wires in advance. So many times in many centers they actually place the arterial and the venous cannula in very extremely high places. Okay. So you need to now have your so start skill. Now this is very important. It's the skill and level of both the perfusionist, surgeon, and I would also say the nurse. That you have, it's a team play where perfusionist is getting ready, anesthesiologist is doing, you are doing all these things there. Now another very important thing, this is primarily meant for the thing, is that you should always call for help. This is a very, very, very important thing that you are saying. In any emergency, call for help. A perfusionist, by law, you can't have a single perfusionist. By law, so tomorrow if you go to Jumratalaya Medical Center and say, I will operate only with one perfusionist, sorry, legally if you run into a problem, no perfusionist should run alone. There must always be another hand. Okay, we'll come to why if we have time. Then carbon dioxide flushing of circuit. Now carbon dioxide flushing of the circuit is something which can be done. Do you know how many days that a dry pump primed with carbon dioxide can be kept for? 42 days, up to 42 days. A wet one can be kept up to a week, but a dry one can be kept as and how much of saline do you need to put when you want to go on cardiopulmonary bypass with a carbon dioxide primed circuit? You don't need anything. You can even run it. I will show you. You can even go on cardiopulmonary bypass with a carbon dioxide flush circuit. If the circuit has been flushed and kept ready, a closed oxygenator with carbon dioxide flushing, you do not need to prime. I will show you why. I think I have it. This is a very thing. Carbon dioxide has been used for angiograms. Do you know that Dos Santos, when he did the first carotid angiogram, he injected carbon dioxide into the carotid artery, and that was a carbon dioxide angiogram. So it can be done. This is actually a carbon dioxide angiogram which is being done. This is it is inverted for the sake, because what is it called? Digital subtraction, this thing, angiogram done, and this is an actual carbon dioxide angiogram, and it is typically done in patients with renal failure. If you want to do an angiogram, one of the options to do is to do carbon dioxide angiography. This is actual carbon dioxide angiogram which we had done many years back. So you can see here that this is a perfusionist. This is my former chief perfusionist who's retired now. Can you run this? Run it. You can see the skill of the perfusionist. But what are you doing at this time? he has put the timer on. What are you doing at this time? You are giving CPR, then what are you going to do? You are doing the sternotomy, you are going to this thing, you have to practice this thing, you have to put purse strings. What is the minimum purse string that is required to go on cardiopulmonary bypass? One purse string where? On the aorta and plonk it. You do not need even a venous purse string, right? You can even stab the RA and put a sucker in and initiate with a sucker. This is actually a timed thing just to show how skilled. It looks a long time, but he will show you the time. When a patient is arrested, everything looks long, no? Or you don't notice the time also. He is actually getting a whole dry pump ready. I mean a wet pump ready now. He will show you the time. So it is very important that you all, when you are a student, should learn how to time yourself. See, when I used to take out an IMA, I always used to tell this much time. When I started doing Ozaki procedure, I said this much time. Each leaflet time, how much. You all have to have self-audit. When I take a vein, how much time did I take a vein? Speed is achieved by precision. It is not done by fast movements. Please remember that. Now see, everything that he is doing is very precise. He is a senior perfusionist and he is doing, and you will see. In fact, if you see the second hand of the clock, but he's actually got the timer on. Can you see? You can see 1 minute 48 seconds. So you have 3 minutes to be on cardiopulmonary bypass, right? And he's nearly ready while we are talking. So this is just to show that you all have to practice this. The perfusionist has to practice. You also have to practice putting your purse string. Note the time, how much you take per string. Try to think. See, unfortunately for you people, can't do it on dogs. He did it. See, in 2 minutes 10 seconds, I think he will tell us that he is ready. He has actually started priming also. He is even giving the suckers. Is that necessary? The only reason the sucker is required is because if you want to put it into the RA without priming. But you will see how much time he is taking. He is in fact putting up an entire circuit. How much, if I give manual CPR, how much can I, cardiac output can I give? This is all you should know. While he is preparing the pump, you are giving manual CPR. How much is it by internal cardiac massage? How much by external cardiac massage? 2 minutes 12 seconds. He is ready to go on cardiopulmonary bypass in 2 minutes. I want to know how much is the cardiac output by external cardiac massage? It's around 1.4 liters. Internal cardiac massage 1.6, but you are still giving shock flows. Even if you are not on complete cardiopulmonary bypass, it's a better thing than being on this. So please remember, a skilled perfusionist in 2 minutes 10 seconds. So you should match him, no? You should be able to go on cardiopulmonary bypass in 2 minutes. So I have shown you, this is a carbon dioxide angiogram. So if you are priming it simultaneously with carbon dioxide, you can run the pump directly. And here you can see carbon dioxide flushing of the circuit. Can you play this please? I'll keep going on till 9 and then I'll stop. Okay? Please, somebody tell me to stop, I'll stop. Because there are nearly some 50, 60...
hospital, Jayadeva hospital is, before priming the circuit, we flush the circuit with carbon dioxide. This is the carbon dioxide cylinder. From this there is this line where we are going to connect it to the reservoir. This is a reservoir. This is a sterile part of it. We are going to connect this carbon dioxide to this. Open the recirculation line. We'll open the recirculation line. The carbon dioxide is on, and we are going to run the circuit. We are seeing to it that one of the port is being opened.
What is the beauty of carbon dioxide? It is heavier than
We'll do this for
air.
about 30 seconds.
So it will always fill the
once it has been circulated for about 30 seconds, we'll stop it. And
you
then
need
what
just
we'll do
30
is
seconds
we'll
to prime it with carbon dioxide. Okay? then he
arterial
will,
filter.
he will
Because
flush.
arterial filter is also a part of the circuit which is difficult to dear.
So in
So
fact, if you
we are going to do this
prime
for
it with
another
carbon dioxide, it's easier to
30
dewear. Or
seconds.
otherwise you'll see them keeping banging for hours together.
We'll do this for another 30 seconds.
So this is how in 30 seconds you can actually prime with carbon dioxide. Now these are all questions. There are a series of things. If you people answer quickly, we can do it fast. High line pressure. Perfusionist says, sir, my line pressure is increasing. Come one by one. Come, you were the, come. Next person be ready. High line pressure. No crosstalk. In the exam you will not be able to do this thing, and in real life, whom are you going to talk to? The line pressure is high. Give a mic please. What's your thought? Perfusion is saying high line pressure. First dissection, is that okay? Do you know what? How many dissections have you seen in your life? No. So now start off with the yes, dissection is one cause, but there is a specific sequence in a dissection that happens. If the line pressure is high, what are the possibilities? How will you go about troubleshooting?
The size of the cannula that are used is very less.
You really think that that would be the primary thought in your mind? You would have, the perfusionist will not give you a small cannula usually. But what I'm not bothered about cause A, cause B, cause C. I am trying to make you think in a systematic way. How would you go troubleshooting it? From where will the line pressure be high? Means from which from the pressure port to the tip of the aortic cannula. So go sequentially from one direction to the other. Tip of the aortic cannula not in position. What could be the commonest cause of a tip of the aortic cannula not being in the correct position? Arey, don't first take of adventitia, it is in the lumen. And you are having a high line pressure. See, this is where, see, every one of you are, see, low probability events have to be recognized, but they are low probability events. But first talk of the common thing. In the exam, please, you get a AVR, what is the operation you will do? Don't say Ross procedure. I was asked by Dr. Sampath Kumar Ross procedure ultimately in my exam. But what is the commonest thing? You will do a standard AVR, because in the exam what we are interested is, are you a safe surgeon, are you a reliable surgeon able to do this thing. Later on we can keep on going higher and higher. Now what is the commonest thing that happens when you have a high line pressure?
The tip is on the reverse direction.
Tip is in the reverse, is abutting the aortic wall. So what is the way you will handle that?
Repositioning.
You will try to reposition. During reposition, what are the precautions that you take when you reposition?
Make sure that it goes in the line of the aorta and not abut again.
Now I will go back to the same thing. What did I tell you? The cheese holes have to line up. What was the thing that you should have done in the starting? While placing the aortic cannula, see, this is where I am trying to tell. Think of it from that time. I said the cheese holes have to line up. How do you, the first thing is, don't get into this issue. Then if you get into an issue, always think this way, how do I not get into this issue? And if I get into this issue, how do I prevent it from happening? When I place the aortic cannula, what do? We open and we have to see a gush of blood, not putuk, putuk, putuk. If you see putuk, 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 don't be happy. Reposition it. That's the time to prevent it. So that is the first hole which you are now preventing it from this thing. You've done that. You've done that, and yet you are now, the second cheese slice has occurred. You start, how do you prevent the second cheese slice of this thing? The perfusionist gives a test run. If the test run is thing, that's the time again. He's not yet gone on cardiopulmonary bypass. You see. So now the third thing is actually in the middle of a procedure. If the line pressure occurs, then you check the tip. Then they see. What are the other things that you could think of? The cannula could be kinked. Then what could be there? Anything else could happen? Could be stamped. Somebody may put their foot on it. People have done it. Everything has happened. If you think that a problem has not happened, it has happened. Everything that has happened in an accident or a modification of the cardiopulmonary bypass circuit is because of the death of some patient. Please remember. So there are multiple things that you have to. So mural placement, check backflow. That's the simplest thing. Whether I am getting it is in the wall, you are obsessed with the wall, no? So wall, it can be Lion King, stamped, obstructed in any manner. Abutting the wall, check backflow, reposition, remove, reinsert. And please remember another thing. This is the rarest. One of the rare things is that a clotted circuit can also cause a high line pressure. Okay? This is especially important for the perfusionist to keep on monitoring their thing. Now, the other causes, if you have a long straight cannula, you have seen this EOPA, all those sort of long cannulas which are not having this thing. You could go selectively into the carotid. Now, how do you recognize that this is now line up the cheese slices. How do you prevent selective carotid perfusion? Check the carotids. You put if you are putting along this thing, isn't it? In many, we ask, you cannulate and ask the anesthesiologist to palpate both carotids. If the carotids are selectively intubated, one carotid is sick. Now, you go on cardiopulmonary bypass, how will you recognize? He says the line pressure is high, but what are the other corroborative features? You will have hyperperfusion on one side of the brain and hypoperfusion on the other. So this side the pupil will be constructed, there will be unilateral diaphoresis and there will be cold dissing. If you have got NIRS, you can see asymmetric NIRS. Okay, so there are many other things there. What should you do? You should immediately go off. Now this is a very, very important thing that you should know. I don't know why that slide is not here, but you can go back. One of the essential things in cardiopulmonary bypass and aviation is, in aviation industry, if I have, there is one thing called V1, V2, V3 and V4. The plane axis, he crosses what is called as V1 when he accelerates. V2 is the place where he is committed to take off, and V3 is where he can never re-land. He has to complete a flyby and land. They have got V1, V2, V3. In the runway, they will be having the markings. Yeah? So if at V1 he reaches, he can apply the brake. At V2, he has to take off. At V3, there is no way he can, he will damage some structure and this thing. You will never reach V3. So now, what were we telling? Why did this come into? So now at what stage, now if I have a problem during takeoff, what is the solution for the pilot? I am having a problem, I am taking off and I have a problem. Immediately he is given priority, and what is it? He is immediately given priority and he turns around and he lands. If he is at the end of the journey, yesterday when we had that arrest, what did I ask? Which is the nearest airport, which is the closest to us, and Bhubaneswar was the closest airport. Now it was a task for us to decide whether to land in Bhubaneswar or not. If the patient had not been revived, I would have told divert to Bhubaneswar. We would have all landed in Bhubaneswar. But since he was revived, his BP was okay, we were made, he was not having, he was conscious. We said, okay, complete it and land in this thing. But what happened there? He was given priority landing. You may not have realized it, but you notice that he immediately, you see, many times they rotate round and then they land and all that. They have what is called as a holding pattern. He never went into a holding pattern. I don't know whether you people realized it. He just, I had actually told them, and then they did not keep him in the holding pattern. Holding pattern is at 1,000 feet, you actually stack the planes. Especially in Delhi airport, you can see it, where some VIP will come. So all of them somewhere near towards Jaipur, they'll be going in series of, they'll just be going round in a big circle. And then one plane lands, and then the next plane goes to the second holding. So this holding pattern is there. So if you are, he was given priority landing. So immediately he landed. You saw he didn't take any turn. He just came in and we just landed and the doors kept open. The bad part of that was the Medivac team should have been immediately coming in. But please remember that. So but in the where most accidents occur during takeoff and landing, same thing in perfusion. Most accidents occur in while going on cardiopulmonary bypass and while trying to come off cardiopulmonary bypass, the least number of accidents occur during stable cardiopulmonary bypass or in cruise. Okay. Now, rising line pressure and falling reservoir level. 9 o'clock. This is the last one because 9 o'clock we'll stop. Shrikant, we stop? Yeah. You can see the remaining things. There are over 50 and odd complications. But if you have a rising line pressure and falling reservoir level, this is what we have to be careful. What it is, stop the answer is this, stop the pump. Think of dissection, roll out dissection. If dissection is there, alternate cannulation site and cool and manage the dissection. Easy to say, difficult to do. I'll give you just this last one. One day, Dr. Prabhudev, my boss at that time, we had a patient who was undergoing a CABG with aortoiliac disease. He had brachial disease, carotid disease, which was not significant but very plaquey aorta. The patient dissected on table. Now think how we managed. I can't cannulate the femorals. I couldn't cannulate the innominator, this thing, all full of plaque everywhere. Think, what would you do? See, this is the importance of knowing alternate sites of cannulation. How would you deal with this patient? Can anyone think? We actually solved it. I actually immediately said, we did it. You can't cannulate this thing. You are having a dissection here on the aorta, you can't. Everything was a blob. Neck vessels can't be used. Subclavian could not be used. I mean, axillary artery could not be used. Femoral could not be used. Huh? Yeah, not for you. So what we did, we immediately flipped up the heart, stabbed the apex and took a long venous cannula, pushed it through the LV into the aorta, and we continued. And then we immediately established it. There is another alternative. There is another alternative, not commonly done, but can be done. The other is what today is being called as samurai cannulation, where you can actually transect the aorta and place the cannula inside and go on cardiopulmonary bypass. Anyway, the patient is, you can't continue the thing. So you transect, identify the true lumen, place the cannula in that, snug it on that and initiate bypass, cool. So, but you never thought of it. You never thought of these possibilities. So, pre-planning in your mind, you must think, if this happens, what is the way? And what is the solution? And how will I execute it? Understood? Very important. Thank you. The rest of the videos are there. I have got a 8-part series in my YouTube channel. You can all see it. Thank you. It's a very, very old one done, I think, in Bombay conference, decades back. The quality of the FD is not exactly that good, but you can learn. But remember, 90% is prevention and 10% is actually dealing with the problem.
Thank you, sir. So now there is a case presentation session, and I request students to keep it fast. Keep in mind that you have just 20 to 25 minutes for each case. And for the case presentation session, I like to invite Dr. Praveen Verma, sir. Sir, for the case presentation, sir, for fast. And Rashekar, sir, Jayant, sir, and Rakesh Naik, sir, please. Please, sir. No, sir, any for case discussion, sir, we have 2 adult case and 1 pediatric case. To present Dr. Uta, just the relevant findings examination. Short case, sir.
Yes, sir.
before starting, you're going to present this fresh case.
Yes.
So yesterday,
Goal directed perfusion, read about it. Dr. Praveen was asking. Goal directed perfusion. It may come as an example. Goal directed perfusion.
You can start off with the diagnosis.
Yes. Sir, my diagnosis is acquired valvular heart disease, probably a stenotic lesion in the aortic valve with a low EF and no signs of congestive cardiac failure or infective endocarditis, probably of a degenerative etiology.
What's the diagnosis? What's the diagnosis?
Acquired valvular heart disease, stenotic lesion, probably a stenotic lesion in the aortic valve with no signs of congestive cardiac failure or infective endocarditis, probably of degenerative etiology.
Aortic valve stenosis.
Yes, sir.
Severe aortic valve stenosis?
Severe aortic stenosis, sir. Severe.
What points favor your diagnosis of severe aortic stenosis?
Sir, first from the history, the patient presented with complaints of dyspnea since 6 months. It increased, progressed from NYHA grade 2 to grade 4.
No, you just tell points in favor of your diagnosis. Okay? No substantiation of other things.
Sir, the pulse rate was, the pulse...
You tell only positive findings suggesting severe aortic stenosis.
How old is the patient? How old is the patient?
63 years old.
Yeah.
Murmur, sir, murmur was heard.
No, when you are asked about diagnosis, relevant history, relevant physical findings.
Sorry, sir.
Relevant history, relevant physical findings. Relevant history.
No, sir. Voice is clear, sir.
Yeah, what's the
Sir,
relevant history?
Sir, the patient presented with the history of dyspnea. Then on examination, the severity of the murmur, grade 4/6, and the duration of the murmur was increased, and this points to a more severe disease.
So when you say dyspnea, and then you say that it's aortic valve stenosis, there's something missing there.
What are the classic
Dyspnea
symptoms of aortic stenosis?
Sorry, sir.
Relevant symptom in aortic valve stenosis. You said dyspnea, and then you are saying there's aortic valve stenosis. There is something missing there, isn't it?
Dyspnea on exertion, sir.
Dyspnea on exertion.
Huh? No, there is something missing there, isn't it? Dyspnea doesn't always correlate with aortic valve stenosis, isn't it? Dyspnea is yesterday we said dyspnea is a sign of pulmonary venous hypertension. Were you able to understand my question? Come in front.
Yesterday, sir told ASD.
ASD. Angina, syncope.
Angina, syncope, dyspnea.
Dyspnea, yeah.
Dyspnea will be the
Last symptoms. Yeah, so does the patient have angina? Does the patient have angina?
This patient did not give a health history.
There is no history of angina. How do you say angina? History?
So we will ask them about any history of chest pain, which is retrosternal.
Chest pain on the left side of the left side?
Retrosternal and left-sided, which can be radiating.
Left-sided?
Yes, sir.
What's the classical description of angina?
So left-sided.
Left-sided?
Constrictive type, which is radiating to the jaws.
Retrosternal.
Retrosternal.
Central. Chest pain or discomfort or heaviness. Often radiating
to the jaws, the left side, left arm.
And left side of the arm. And relieved by
rest and by anti-anginal drugs.
That is the
and
classical.
lasting for 30 seconds to 30.
And with or without sweating. There is a classical description of angina. The patient, does he have angina?
No, sir.
She denied history of
Syncope?
No, sir.
She denied history of syncope.
She didn't have history of syncope. And she has dyspnea on exertion.
Yes.
Okay, okay.
These three symptoms, angina, syncope and dyspnea, are the classic triad symptoms of aortic stenosis. What is the prognostic implication of these symptoms?
If the patient presents with angina and not treated, the life expectancy is 5 years.
It's not life expectancy. The survival.
The survival
probability.
is. Yes, 50%.
Patients with angina have the best prognosis.
Yes.
What about dyspnea?
Poor prognosis, severe years.
What is the probability of survival at the end of 2 years?
2 years.
Yeah, 50% only survive at the end of 2 years.
2 years.
So that is the last to appear actually.
Why do you think angina occurs?
Sorry.
Why do you think angina occurs in aortic valve stenosis?
There is a demand-supply mismatch because of the left ventricular hypertrophy.
The demand
The
decreases
demand is
due to left
increasing,
ventricular hypertrophy. The supply is decreased because the diastolic timing is decreased.
The answer is decreased coronary flow reserve.
Flow.
Okay. What's the reason for syncope?
Low cardiac output state in that.
Low cardiac output state. Syncope. Yeah. What's the answer? What's the answer?
He is giving a clue.
He gave a clue.
So the demand cannot increase.
What's the reason for syncopal attack? Don't be fixed. Fixed cardiac output.
Aortic.
Fixed cardiac output.
Fixed cardiac output, yes.
Fixed cardiac output. And what's the reason for dyspnea?
Left atrial the hypertension.
Due to?
backflow.
Due to? Due to?
Due to the high LV pressure.
LV pressure.
So due to the hypertrophy of
That.
What happens to the LV mass in aortic stenosis?
increases.
Increases.
So there is LV hypertrophy.
LV
What type of
hypertrophy.
hypertrophy is it?
Eccentric.
Concentric.
Concentric hypertrophy.
What is the difference between concentric and eccentric hypertrophy? Where do you get eccentric hypertrophy?
Aortic regurgitation.
So again, suppose we have an isolated aortic stenosis patient, you have an isolated aortic regurgitation patient. So one has a concentric, the other one has an eccentric. Which do you think has more LV mass?
Concentric.
Okay, we'll go forward. How do you calculate the dose of cardioplegia in arresting the heart? What is the dose of cardioplegia?
What's the normal dose? First
Normal
dose. First dose, arresting.
We are having the different cardioplegia. What is the normal cardioplegia which you use in your institution? You tell that dosage.
Let it
Name
be
the
any dose.
standard
So any cardioplegia solution. It is calculated by per kg body weight, isn't it? But the body weight is not a true depictor of the cardiac mass. In aortic stenosis, which is the most important thing that you should ensure during surgery,
LV
is adequate myocardial protection. Among all the hearts, these are the most sensitive hearts and you will have to take care of myocardial protection. And in this, the LV mass is unusually high. So the cardioplegia being calculated for body weight may not be adequate for the LV mass that you are actually handling it. So the cardioplegia solutions require to be higher.
Yeah. So does this X-ray fit your diagnosis? Aortic valve stenosis? This is the same patient's X-ray?
Yes, sir.
62-year-old. I don't think so. Is it a female?
Yes, sir.
Oh. Yeah, okay. Does it fit the diagnosis of aortic valve stenosis? Yes? Is there any cardiomegaly?
Yes, sir.
Do you expect cardiomegaly in aortic valve stenosis?
Yes, sir. If it is there, if EF is low, in a preserved EF, heart is smaller.
So this is a
Low EF patient.
systolic heart failure.
Yes.
Yeah? Systolic heart failure. Systolic failure. Aortic valve stenosis is systolic failure?
Diastolic. Yes, sir.
This one. There is cardiomegaly, isn't it?
Yes, sir.
Yes, sir. The CT
Yes.
ratio is increased.
CT ratio is increased.
So systolic heart failure.
Yes.
Aortic valve, what are the stages of aortic valve stenosis? What are the stages of aortic valve stenosis?
What are the stages?
Stages, yes. Do you know or not?
Stages, sir, in what?
How it progresses. It progresses through a natural history, isn't it?
Yes.
Yeah, what is that?
It's, every year, sir,
Initially, how is the ejection fraction? Is it normal, high, low? Aortic valve stenosis. Ejection fraction in aortic valve
Ejection
stenosis. Huh?
ejection fraction initially is normal.
Is it normal? Aortic valve stenosis.
First it is low, then it...
How can it be low and then
No,
high?
I didn't understand.
Why are they asymptomatic for a long time?
Aortic valve stenosis, initially the ejection fraction is supranormal, isn't it?
Yes.
Why?
Because the heart has to pump against
It's not pumping.
the LV.
It's not pumping. There is hardly any end diastolic volume left in aortic because it's concentric hypertrophy, isn't it? So ejection fraction will be high. You typically see ejection fraction of 65%, 68%, etc. in aortic valve stenosis. Then what happens? Next stage. Reduction in ejection fraction. What is that called? Have you heard of term called afterload mismatch? What does that mean? Is it a true systolic failure? No. So initially then ejection fraction drops, but what happens if
When the afterload increases...
yeah, it is most of the energy used for opening the valve. So there is a false decrease in ejection. Hear from me. There is a false decrease in ejection fraction, but still the heart size will be normal. Then third phase is the true systolic failure. Why? So remember, first there is a hypertrophied heart with a supranormal ejection fraction. Then it drops to afterload mismatch, but it is not a true systolic failure because it is mostly because the energy is expended for opening the aortic valve. Heart size is still normal. Then you get a true systolic heart failure because of replacement fibrosis. The hypertrophy gets replaced by fibrosis. Then you see the heart enlarging. Isn't it? So in which phase is this? Systolic heart failure. So typically you find ejection fraction of less than 40%. Is there any evidence of pulmonary venous hypertension here?
Yes.
What is that? Show.
So,
the hilar density is
curly A and B lines. Curly A, B, curly A and curly B. Sir, in the apex and at the base of the lungs.
Base of the lungs? Show. What are the stages of pulmonary venous hypertension in X-ray?
Sir,
what are the stages of pulmonary venous hypertension in chest X-ray?
Sir, initially at the apex, firstly, when the pulmonary venous hypertension is between 15 to 20.
What do you see? What do you see?
Sir, prominent vessels in the apex.
It's called cephalization. or inverted cephalization or inverted mustache
Oh
sign.
yes, invert mustache.
What is the usual wedge pressure that time? LA pressure? What will be the LA pressure when you have CA cephalization?
15,
12 to 18.
18.
When will you see curly lines?
Curly?
When will you see curly lines? What is the LA pressure?
Up to 20.
18 to 24.
24.
After 24?
Curly B lines or alveolar edema.
Pulmonary edema.
Alveolar edema will be.
Pulmonary edema. These are the 3 stages. So this, I'm not seeing any curl. Is there any curly lines here?
Yes. So on this we can.
Cephalization I can see. Yeah. Curly, yeah. Is there a LA enlargement here?
LA. Yes, sir.
Sure, where?
So it's from the computer. From the computer. Yes.
So there is.
So it's playing of the
LA enlargement. Left atrial enlargement.
Sir, here. This and
So
here.
the trachea coming down into the bronchi, there's playing of the.
So do you want to change your diagnosis? Based on these findings, do you want to change your diagnosis?
Sorry, sir, I can't.
So somewhere here. Inside one.
Double chest.
Straightening. Yes. Yes. Sir.
This side, sir. Don't know, man.
Yes, it's playing.
Can you see this one? This thing?
Yes.
Okay.
Yes.
And there is a double lateral shadow.
Lateral shadow. Yes. RA is also diagnosed.
So based on this, do you still think do you want to go back and see your diagnosis? You said only severe aortic stenosis, right?
Sir, aortic knuckle is also prominent, so.
Now, what are the findings that you see on X-ray which does not directly correlate with aortic stenosis?
RA is also diagnosed.
How do you explain the enlargement of the RA, number 1?
So because of the pulmonary venous hypertension.
Pulmonary
and
venous hypertension gives rise to enlargement of RA?
No, sir. Pulmonary arterial hypertension.
Is there evidence of pulmonary arterial hypertension in this? Okay, go ahead. No, it does not correlate actually. Yeah. So we will assume, for a moment we will assume this is a case of pure aortic stenosis. Now you go ahead with your surgical steps.
Yeah, what do you think? ECG. How do you, in exam, what are the things you will say in ECG? The basic things in ECG. Yeah.
Sir, we will see in the V1.
No. First you say, is standardized or not?
Standardized.
Is it standardized?
Yes.
Yes,
What is standardization?
25
millimeter per second.
No. There, see this here?
10 mm per.
Yeah, what does it mean?
That's a calibration mark, so that means for the vertical deflection for that 10 millimeter per millivolt. So we can correlate that height of the
that is
QR.
1 millivolt,
Yes, sir.
isn't it?
Yes, sir.
Yes.
Then, so it is you say that it is a standardized ECG, means that voltage should be standardized as well as speed should be standardized, 25 millimeter per second. That is the first thing, standardized ECG. Then second,
The rhythm, sir.
Rate.
And
Rhythm
sir.
and
rate.
Rate and rhythm.
What is the rate?
So about 100 beats per minute.
How do you calculate the rate?
So if we count the number of boxes between the two RR intervals, then 300 divided by the number of boxes.
Number of large squares.
Large squares, sir.
Or
If you are counting the small squares, 1500
1500 divided by small
Oh,
squares.
we can count the number of arts.
1500 divided by small squares. So rate, then second is rhythm.
Rhythm, sir.
What's
Seems
what's
to be in
rhythm?
sinus rhythm, sir.
How do you say it's a sinus rhythm?
So that the RR intervals are equal, and every R is every complex has a P preceding the QRS complex, sir.
P followed by a QRS with a
complex.
regular rate.
Yes, sir.
He says that it's a normal sinus rhythm. If you have been asked some more this one, you say that the P wave morphology and axis is normal. That is lead 2. Lead 2, you look at the P wave morphology as well as axis.
Yes, sir.
We know that is this one. Then rate, rhythm, then axis.
The axis by the
What axis?
Left axis.
Yeah, how? Could be left axis. How do you say it's a left axis? So which are the leads you will look?
1 and AVR.
1 and
AVR.
AVF.
AVF.
Lead 1
AVF.
and AVF.
AVF.
The axis is usually between that. So you will have positive deflection both in lead 1 and AVF for a normal axis. You look at here. Lead 1 has a large
positive
R wave
deflection.
and the AVF has a small R wave.
And
So where could, and look at the AVL, very tall R wave.
R wave.
Yes.
AVL is in which axis? AVL goes in this direction. So where could be the axis?
More left deviated, sir.
Lead 1, AVF,
AVF.
AVL. You get tall R waves in AVL. That means axis is
Left deviated.
left axis, probably somewhere here. So it could be a left axis.
Left axis.
Yeah. Does it fit your diagnosis?
Yes.
Could be
Yes.
because of left ventricular hypertrophy. Is there any left ventricular hypertrophy here?
Yes, sir. In V1, the S wave, deep S wave,
Deep S wave in V1 and
V1.
tall
tall R waves in V5, V6.
V5 and V6. You say that there is a this one.
LVH.
LVF. Is there any evidence of systolic heart failure in ECG here? Do you know or not? Any evidence? What are the evidence of systolic heart failure in ECG?
The length of the R wave.
No. There is evidence of left ventricular hypertrophy with strain pattern, but there is no evidence of
Heart failure.
fragmented QRS or widened QRS.
Wide QRS.
The wide QRS or fragmented QRS. This is evidence of systolic heart failure because of interventricular conduction blocks.
Yes, sir.
So the, in ECG doesn't suggest a systolic heart failure. Echo?
One question on ECG. What ink is used, do you know?
Sir?
What ink is used?
Sorry, sir.
Ink.
Sir, that is a thermal ink, sir. It will.
It's a thermosensitive paper.
Thermosensitive.
Yes, sir. No.
The paper itself draws like the receipts we get. Same technology.
Okay. Echo?
So echo is showing a tri-leaflet thickened calcified aortic valve. The peak gradient of 150 and mean gradient of 104. Mild
Annulus.
AR. The aortic annulus sizes are mentioned. There is a
23.
moderate tricuspid regurgitation, mild MR and mild PR. Sir.
PA pressure is? 48.
TRPG.
And is the LV dilated?
And diastole 54.
How is, what is the LV dilated?
Yes.
Something is not correlated.
For the dimensions of the LV that you have shown, 45 and 54,
yeah.
What is your inference? Is it
9
sorry? No, they are not,
It's not
hugely
dilated.
enlarged or dilated. Okay,
It
that
is
is
not
number
that
one.
much.
The ejection fraction is 35%, aortic stenosis, and there is severe PAH. All these combinations, something is not fitting properly.
LA is 43.
Other valve normal.
No, the other valves were all normal except for moderate TR,
Yes.
mild MR, and mild AR.
Go back to.
Go back on that. There is mild in this only.
Moderate TR, mild MR, PR, sir.
Yeah. So this patient has a peak gradient of 150 and a mean gradient of 104. That's the same patient, another patient has got a peak gradient of 50, and a mean gradient of 20. Which patient is sicker? You understood?
Sir, the one with the lower is decompensated.
One patient has peak gradient of 150. Another patient has got the same findings. Another patient has got a peak gradient of 50. Which patient is more sick?
That means the disease have progressed, severity is increased, sir, when the peak gradient falls.
Now, are you happy to see a high gradient in severe LV dysfunction or a low gradient in severe LV dysfunction?
High gradient.
Higher gradient would
Higher gradient.
worry me less. A higher
Why?
gradient would worry me less.
Why?
The difference in the pressure at the alveoli is higher.
Distal it is lower.
Lower.
So it means to say the LV is capable of generating a higher
Pressure.
So that's why the gradient is
High.
Yes, sir.
So,
So,
contractile
when it
reserve is
decrease that, it means
contractile reserve is preserved
Preserved.
in patients who have got
higher
adequate
gradient.
gradients.
When it goes into failure,
If the gradient is 50,
Reduced.
what additional investigations you may do? If this gradient is peak gradient is only like 35, same findings.
Low flow, low gradient is.
What another?
Dobutamine.
Will you confirm?
Dobutamine test.
stress test.
Stress test. Sir, after giving dobutamine, there is an increase in flow and velocity. When
Reversibility.
No, the same principles that we tried to explain before, you have to apply it here. So there is a low gradient AS, okay, and LV dysfunction. Now you want to give a dobutamine stress test. What is the objective?
to decide whether to take the patient for an EV
Okay,
or not.
one patient the gradient increases, the other one the gradient does not increase. What is the inference? Fine, go ahead, give dobutamine. Now you tell what is your observation. What do you want? What do you desire?
We want it to increase. There
With
should be a
the-
change.
So what does it indicate?
It
That we can
indicate-
go ahead with aortic valve
Sir, that
replacement.
the failure is
Pseudo severe AV.
Yeah, no, it's not.
It's not a
Contractile reserve is
contractility is
preserved.
preserved.
a preserved contractile reserve.
Shall we go ahead? We will go ahead with the steps of surgical steps of aortic valve replacement.
CT aortogram. CT aortogram.
What is the purpose? What do you want to evaluate?
The aortic root and ascending aorta.
With respect to your case,
Don't you want to do a coronary angiogram for this patient? Coronary angiogram?
Coronary angiography is
Patient is
63-year-old with
Okay.
a low EF. And
So
global
what could be
LV.
the primary pathology? What could be the pathology? Echo, clinic, age,
Calcified aortic valves, the degenerate.
due to? What could be the cause? Sinus is 38, STJ is 30, ascending aorta is 40. What is the commonest degenerative aortic valve disease
Seen,
that happens between 40 and 70 years of age?
Sclerodegenerative disease.
Yeah?
Sclerodegenerative disease.
What is that?
Sclerodegenerative disease of aortic. Hypertensive.
40 to 70 years of age, patient has severe aortic valve stenosis with ascending aortic dilatation. What could be the cause?
senile degeneration.
Senile degeneration. Senile degeneration, unless it's a rapidly senile patients, usually senile degeneration is above the age of 75, and it's particularly described in 80 years of age, more than 80. This age group?
60.
62.
63 years old.
What could be it? It's a congenital abnormality.
Bicuspid
but
aortic
they have
valve.
not mentioned.
Bicuspid
the-
aortic valve. Why? Is
Bi-reflex
it easy to diagnose bicuspid aortic valve stenosis when it is calcified in echo?
No, sir. CT aortic valve.
So it would be most likely it's a bicuspid aortic valve stenosis.
Yes, sir.
Yes?
CT aortic.
CT? CT scan?
Dilated ascending aorta is.
It's on CT.
Bicuspid.
Bicuspid.
Yeah. Ascending aorta is 46 by 43.
45.5 mean.
Okay. Sacula bulges at the level of main pulmonary artery.
This sir explains severe pH.
Okay, what do you want to do?
Among all these values that you are seeing, which value interests you the most for such?
Ascending aorta is.
No, the ascending aorta is 46. Even if it was 50, it did not matter much. Okay, but there is some
Annulus size, sir. Annulus size.
annulus size. Yes, of course, to plan for the valve replacement. But on the table, you can change it. If at all it was higher by your sizing, you would put a bigger valve. One value is very important. That is the size of the aorta below the innominate artery. That will determine your clamping technique, isn't it? It will also change
37.
how much you are going to extend your resection if you need to resect.
Okay, what do you want to do?
I would like to counsel her and offer her the option of a surge.
What is that?
So I would like to
Aortic
counsel her
valve
for the
replacement.
aortic valve replacement. Sir.
Will you should we look at the coronary angiogram in this patient?
Coronary angiography is done.
So
No,
the last line.
what do you specifically look in
You read the last line.
What specifically look in bicuspid aortic valve stenosis? Other than looking for any obstructive coronary artery disease,
Ostia of the coronaries.
what are the specific things as a surgeon you will look
the
for?
dominance of
Dominance, yes. What are the abnormalities in coronaries you see in
High
because it is bicuspid where the coronary
Opening
ostia
of the
are
ostia.
taking off from. Sir.
What are the anomalies which is interest you as a surgeon? Bicuspid aortic valve. Short left main
short
and
left main.
and paracommissural origin of coronary arteries. Near the commissures, coronary arteries can origin. So when you put a valve, you make sure that you don't obstruct the.
Obstructive commission.
The ostia.
So these are the two things: short left main and paracommissural origin of coronary
Coronary
arteries.
arteries.
That should be specifically of interest to you. Okay. Okay. Go ahead. What do you want to do?
So sir, I will counsel her for the aortic valve replacement.
What about ascending aorta? 46 mm.
45.5.
46 mm. what is the current recommendation in guidelines? When you
The
have
bicuspid aortic valve, if it is more than 45,
40.
4 point,
Replacement of
more
the-
than 4,
Hmm?
45, more than 45.
More than
Bicuspid.
45.
Then
More
we
than
should go for a
4.5
replacement.
centimeter. You are supposed to do a concomitant,
4.5 centimeters.
concomitant ascending aortic or ascending aortic replacement.
So in this particular case, what is your plan?
Your plan.
What do you want to do?
Aortic wall replacement.
Aortic valve replacement. You want to leave behind the ascending aorta? Your choice, that's fine.
No, sir, not.
You want to replace the ascending aorta? Till where?
Just before the origin of.
Just before the origin of?
1 centimeter before the origin of innominate artery.
Now the classical, this is ascending aorta, hemiarch. It has to be below the innominate
Yes.
artery. You are not supposed to even leave a small cuff of ascending aorta, because it can progress and have a, even though it is not that malignant, still there is a chance of a dissection at that area. So ideally AVR plus ascending aorta, with hemiarch replacement, and it is a class 2A recommendation, I think, for a concomitant aortic valve replacement.
So with this plan, how do you change your cannulation techniques and how do you continue the procedure?
Where will you cannulate?
You want to discuss that or shall we go to aortic valve replacement?
Just discuss
You
AVR,
can
no?
do-
Why are you discussing such an extensive procedure, Jayant?
What's
Just
that, sir?
Let her do the aortic valve, no.
AVR.
Fine.
Okay.
Let us assume the ascending aorta size is normal.
Ascending aorta is 3.5 centimeter.
Yeah.
Okay.
Go ahead.
Go ahead. Ascending AVR.
Sternotomy done, pericardiotomy done.
Which valve?
So her age being in 63,
Yeah?
It should be patient's choice.
Yes. So this is asked in the exam. Class 1 indication is always patient's choice. Patient preference is the class 1 indication, and inability to take anticoagulation. These are the two class 1 indication. All other age related,
Age and
this is
all
all
second-
class 2
yes,
indications.
class
So the patient cannot take anticoagulation because of bleeding diathesis, put a
And cannot
bioprosthetic
follow
valve, and patient preference. These are only two class 1 indications for choice of valve. Okay. So I am the patient, I want a bioprosthetic valve.
Go ahead.
Go ahead.
Pericardiotomy done. Now you plan and execute the procedure.
it's a
Pericardiotomy is done. After
Yeah.
that, we will take the purse strings just before the innominate artery origin.
Fine.
And we will go, I would like to go for a bicaval cannulation.
Bicaval cannulation in aortic valve replacement.
Yes.
Any specific advantages you are thinking of? Is there anything in your mind why you want to do?
Rewarming of the heart, the blood.
Which part of the heart will get rewarmed in a single atrial cannulation versus a double atrial cannulation? Specifically with that cannulation difference, is there any selective rewarming of any tissue in the heart?
Right side mainly.
Yeah. One of the claimed advantages of a bicaval cannulation in such procedures over single cannula is actually rewarming of the SA node.
SA node.
Okay. I don't think any other part of the heart there is a huge difference. So go ahead. Next.
After bicaval cannulation, we will take the patient on CPB.
As soon as you go on bypass, patient fibrillates. What is the cause in
we'll
this
take-
particular patient?
RSPV event we would like to put
No,
first.
it fibrillates. What is the cause for fibrillation? What are the causes for fibrillation of the heart as soon as you go on bypass?
Distension and cold.
Fine, fine.
Temperature.
I agree. I agree there is a possibility of distension. What is the cause for the distension? So there could be associated AR, isn't it? That is number one. And the second most common mistake usually, which what happens is the first assistant usually divides the arteriovenous loop long before cannulation. In aortic, usually it should not be done. It should be done just before
Just
going on
before the
bypass.
cannulation.
Because what is the temperature of the perfusate?
4.
No, no, no. Perfusate in the arterial line, it will actually go to the temperature of the operating theatre. Usually it will be 18 to 20 degrees centigrade. That's quite cold. Okay. So, and heart is 36 degrees centigrade. So, as soon as you run the pump with that cold perfusate, and if there is a regurgitation, it will fibrillate. So, okay. So, these are the common causes. Fine. Now, you have gone on bypass, heart is still beating. What do you want to do? Go ahead.
We'll put a vent in the LV and try to...
When you are trying to put a vent, what is the risk involved?
Sorry.
You have gone on full bypass. Now you are saying that you want to put a RSPV vent. What is the risk involved in putting the RSPV vent at this stage?
The heart is with a CPV, this is still showing pulsatility. Heart is still ejecting. Is it safe to put a vent? What do you mean by if the heart is ejecting?
We have to arrest the heart with
If the heart is ejecting on full CPV, what does it mean?
He is saying that the heart is ejecting on full CPB. What is he trying to say
that
by saying ejecting?
Is, not very clear.
Anybody in the audience?
Oh, sorry.
Sorry? Yeah, there is a regurgitant volume being back in the left ventricle which is being ejected. That is what is telling that the heart is ejecting. How do we come to know that the heart is, how does he know that the heart is ejecting?
Activities.
Anybody? It is okay. It is because on CPB it should be a monophasic arterial curve. Okay, whenever it is pulsatile, it means that the LV is ejecting. So that is how he has come to know that the heart is ejecting, and the cause for that is probably an aortic regurgitation and the LV is getting filled up. Okay, that is one. Or it could be partial bypass, means the return may not be complete. How do you know that the return is not complete? How do you know that it is not full bypass? How much should be the CVP on bypass? It should be 0. Okay, you cannot have any CVP pressure, so that establishes that it is a complete bypass. Yeah, now we are on full bypass.
Collapsed. Nari also.
So coming back to my question, it was about when the heart is empty, okay, and you try to put an RSPV vent, it may suck air, okay, so and you can have air embolism.
We should keep the heart ejecting.
Yes, you partially fill the heart so that the pulmonary veins are flooded with blood, and then you poke so that actually you have a spurt on the pulmonary vein. Then you introduce the RSPV vent if you want to do this, putting the vent at this stage.
Yes.
What type of vent will you use and what precaution you will take? You are inserting vent before clamping the aorta. So what precautions you will take, or what type of vent you are using?
The steps for venting the heart.
LV.
LV vent only we are talking.
What are the ways of venting a heart?
Again, the question is
Root vent is there.
Have you seen the catheter vent?
Yes.
How it will be? How many limbs it will have?
Rajshekhar, we can't hear you.
How many limbs it will have?
2.
Vent catheter, LV vent catheter.
Okay, we will stick to the RSPV. Anybody wants to answer that?
Precautions.
Have you ever seen the LV vent? How many have you seen?
Everybody has seen.
Then one of you volunteer to tell how many limbs will that catheter will have?
2 limbs.
So what precautions to be taken if you are going to insert the vent before the clamping the aorta?
Just stop the ventilation and fill the heart.
One of you stand up and answer. Can you repeat?
Yes.
We have to clamp the second limb so to prevent the air from being...
There are 2 types of vents, one with the side port, one without the side port. So the one he's talking about is one with the side port, it has to be clamped. And what precautions he's asking, the first precaution before you put an RSPV vent is to put the root cannula. You're not answering that.
Okay, now let us assume that you have put the RSPV vent and you have snared it. Do you tie it or you don't tie it? whenever we snare a structure like aortic cannula, you snare it and then you tie a knot. What is the purpose of tying that knot? You put a RA cannula, then you snare it and then you tie it, isn't it? What is the purpose of tying that? Anybody? The purpose of tying the knot is to make sure that distal to the knot, the length of the cannula is constant. Okay, that is the purpose. So in case of an LV vent, if you tie it, it will be constant distal to the knot, and you are manipulating the heart. So if it is constant inside, then it can perforate the LV. So usually it is preferable that you don't tie the RSPV vent.
Yes.
Go ahead. You have put the RSPV vent. You did not understand that?
No, I understood, sir. So because we the heart, the length inside is constant. If we tie it down while maneuvering.
So whenever you are manipulating after cardiopulmonary squeezing, then because the length is constant, it can perforate, and things have happened.
We need to leave it free.
So this is an important thing, that you should not tie the RSPV vent.
How do they check it's in the LV, Jayant?
Sorry?
How do they check it's in the LV?
How do you ensure that it is in the LV?
Pressure line.
Visualization.
No, you wouldn't be able to see.
It's a palpate.
Oh, that hypertrophic LV you can palpate, huh?
No, in aortic stenosis, it will be like a cork ball. It's so hard, you will not be able to assess.
What will be there in your OT at the head end?
The TET, in the T,
Yeah.
esophageal echocardiography.
Yeah. Okay. Now you have put the RSPV vent. Go ahead.
Okay. So we initiated bypass and myocardial protection. Up to how much degrees you want to cool the patient? We are on full bypass, vent is inserted, we are going to ready to clamp, but how much temperature we want to cool the patient?
32.
Huh? And it is a hypertrophied, severe but dysfunctional heart. And what type of cardiopulmonary you are going to use?
St. Thomas blood.
Huh?
So you don't have to be apologetic about that kind of cardiopulmonary. Whatever you use it. You tell.
Del Nido.
Okay.
Del Nido fine, St. Thomas fine, Crystal
Del
Heart
Nido's
fine.
recommendation is that in adult patients it should be cooled down to 28.
28.
Okay. So now ready to clamp. So what is your cardiopulmonary strategy? Do you want to give through the root or through the osteo?
Aortic stenosis we can give through the root, but if there is a component of aortic regurgitation.
No, not if. In this patient, do you have or AR or not?
AR is there,
In
sir.
this patient,
So
you want to give root cardiopulmonary or osteal cardiopulmonary?
Osteal cardiopulmonary.
Now you tell the steps of, after the clamping, how you are going to deliver the cardiopulmonary.
After clamping, sir, we'll give an aortotomy incision.
You will just clamp?
Clamp and cool first.
You don't fibrillate the heart? Do you follow that, fibrillating the heart?
Yes.
Why do you fibrillate the heart?
Air is to check whether the plagia is being.
No, first you are going to fibrillate the heart, then you are going to clamp, and then you are going to open the aorta, isn't it? This is the standard step. Question is, why do you have to fibrillate the heart before you open and before you clamp and open the aorta?
To stop the mechanical.
Sorry?
To stop the mechanical.
Correct. But why do you have to fibrillate?
Purpose of fibrillation. What will happen when your heart fibrillates?
Sir,
it will not eject.
That's the purpose.
Yes, that is the purpose. Otherwise the blood will splatter on your face. That is number one. And suppose you have a delay on opening the aorta. The heart is ejecting against a cross clamp. Again, that is not desirable. Okay, these are things, simple practical things. So that is the purpose, and that is why we fibrillate. And then you continue. You open the aorta. How do you plan the incision on the aorta?
1.5 centimeters above the origin of the RCA.
Can you really see the origin of RCA?
No.
You can't see.
So
you can't base your incision imagination based on some imaginary
So that
structure.
ascending aorta
You should have a standard landmark,
divide
isn't
into
it?
thirds.
So what structure can you see based on which you can plan incision? One, the purpose of the incision is adequate exposure of the aortic valve.
Yes.
Okay, so you should be as close as possible to the aortic valve. And second purpose is there should be no damage of important structures, that is RCA. Okay, so don't go anywhere near where the origin could be. Okay, you just stay above it, and what is visible is actually the sinus. That is always seen, the sinus of the aortic root, isn't it? And which is the sinus that we would aim to go? It is the non-coronary sinus. So that lies between the right atrium and that is the torus aorticus region. So you go to that place, and then you extend the incision as much as possible to provide adequate exposure. You stay above the STJ because that is the upper limit of the commissural height, isn't it? So these are the principles behind the aortic incision, and it is an oblique incision that gives the widest exposure. Transverse will limit your exposure.
What is the name in brief for this incision?
Inverted,
name given?
Inverted hockey stick.
Yeah, they would expect you to say inverted hockey stick incision. Yeah.
And will your incision differ mechanical versus bioprocesses? If so, why?
What's the difference between the
The
mechanical?
strut height of the bioprosthetic valve,
is
so
higher.
we have to leave an adequate tissue to accommodate the sutures for the strut.
Suppose a patient is asking for a sutureless valve. So how will you plan your incision?
Do you know about the sutureless valve?
Yes.
What is the difference in the incision?
If you have seen, you can tell. Otherwise,
If you have seen that, it's a higher.
The incision is higher up because.
what is the name of that valve? See, all
Do you-
the latest generation valves you should know.
Sutureless. Yes.
Do you want to transect that and do it? In,
Some
Would you
some
pre-
surgeons do its transection.
So all these tissue valves are like bovine. What is bovine?
Bovine is derived from the cow. Pericardium.
pericardium.
Of the cow.
Porcine.
Porcine is derived from the
Pigs.
pigs.
Equine.
From the house.
Ovine.
Yeah, just 1 minute steps. You open the aorta, then give cardioplegia, arrested the heart, then
What precautions will you take?
no,
to
no, no, exercise then what is the next step? You open the aorta, gave cardioplegia, arrested the heart. Then you want to do an aortic valve replacement, isn't it?
Then
What is the next step?
So
Arrested the heart.
Arrested, heart is arrested, gave cardioplegia, nicely arrested. You expose the valve. What is the next step?
inspection of the valve for calcification.
You inspected, you are satisfied. Okay, next step.
Excise.
Excise the valve. Where will you start excision? Classical description.
From
Can
the-
excise anywhere. Classical description of excision of the valve.
From RCC, NCC,
No, in the middle of the right coronary cusp. That is
left to the right.
middle of the right coronary. That is
Middle
a
of the right
classical description given in Kirkland. Middle of the right coronary, you start excising the valve. After that,
We will go towards the LCC.
Sir said middle of the RCC. Why? What is the rationale?
See, it is not only in aortic valve replacements. All surgeries related to the aorta, starting from aortic valve replacement till cono, SAM resection, everything. You have to remember only that point. That is the trough of the right coronary cusp. The trough of the right coronary cusp is the line which demarcates safe and unsafe zone.
Safe, yes.
The zone towards you, that is towards the right of the trough of the RCC is your safe zone. Sorry,
Unsafe,
dangerous zone.
unsafe.
Away from you is
away
the
from
safe,
safe
zone. Okay, and so is saying that you go to the safe zone first,
Yes.
and then extend your excision.
Yes.
It's what?
There are no vital structures like AV node or IVS or AML. They are mainly on the right side. So even if the incision extends, there is no
which
damage.
is on the right side of right coronary cusp.
Right side of the right coronary cusp is the AV node. AV nodes. Sorry, right of the right.
No, conduction. You just say conduction.
Conduction.
Yeah.
Conduction.
Venous septum
And
and
go and
conduction.
find out where is the AV
Into-
node. It's not there. Okay.
Yes.
And then You excise the valve, then you decalcify. How will you take sutures for a bioprosthetic valve? Simple, one answer. What is the type of suture you take for a bioprosthetic valve?
Bioprosthetic valve.
Continuous?
Non-inverting.
Everting.
Is it a continuous suture line?
You can use continuous.
Continuous.
But
No,
always
what do
say
you
that.
do?
Always
Evert
say,
it. Or everting horizontal.
everting. Bioprosthetic valve.
Inverting horizontal.
Inverted.
Inverted mattress.
Pledgeted. Mattress suture.
Mattress suture.
What size of needle? What suture? What size of needle?
Needle. 13
What-
Ethibond is the suture.
Ethibond 20.
Needle size 30.
What size of needle? 25 mm?
26.
26 mm.
26.
Aortic valve. That's for mitral. Is
17
17 mm.
17 mm.
17 mm. 20, 30.
20.
20 interrupted. Pledgeted. Ethibond is what? What? Polyester. Polyester switches. And then you size the valve. How will you size the valve? After this we'll see.
Bioprosthetic.
Yes.
This valve size.
Yeah. It has got two components, isn't it?
Yes, sir. That's supraannular.
Supraannular and valvular.
One is the replica and other one is goes in the intraannular. Both has to be matched.
Why should every company have a different sizer? If it is the same, 23 mm, why should different companies have different sizers?
Sir, due to the design, the internal diameter is different. Sir.
Sorry?
Sir,
You are measuring the external diameter or internal diameter?
So, the external diameter. Sir.
So it should be all external diameters for all the valve sizers, no?
Okay. We have done the aortic valve replacement, but you are unable to come off bypass. Tell 1, 2, 3, 4 reasons. What are the reasons for not coming off bypass? Checklist.
Leaflet is stuck. The stuck leaflet is there.
You are replaced with a bioprosthetic valve and you are unable to come off bypass. What could be the reasons?
LVOT.
To have maximum discussion, you can also volunteer. If
Sir,
anybody
ostial
wants to
occlusion.
answer, they can come up.
Sir, in bioprosthetic valve, one of the stud is occluding the ostia, left main.
Stand up.
Sir, in bioprosthetic valve, one of the stud is occluding the left main ostia.
Oh.
And sir, we are taking bite on the right and non-coronary, we are taking on the AB node area.
Is it common, have you seen any time
no, sir.
obstruction of the left main ostia? Which ostia is commonly gets obstructed?
RC.
Yeah,
Right
the right. And Shrikant, shall we?
Thank you.
Thank you, sir.
Thank you, sir.
Okay. So common things first. Whenever you are coming off bypass, first you have to check whether patient is getting ventilated or not, and we have cooled down the patient, so adequately rewarmed or not. What is the potassium? What is the hemoglobin? You have to see the ABG and if lungs are getting properly ventilated. Then gradually fill the heart and see the wave trace. It should be ejecting. Then heart is when is adequately filled and try to come off. That is a strategy to go on. But even doing all these things, if you are not coming off, one could be either patient might be in the block or air in the coronaries or inadequate myocardial protection or like coronary ostia obstructed.
Thank you, sir.
Just 1 point more, Jayant, 1 point more. See, she involuntarily said bicable cannulation. Remember, the bicable cannulation will save her if she on the table decides to give retrograde. She can just snare the SVC, IVC, open the RA and give retrograde, no guesswork inquired. That was a good thing she said, but she did not know what she was talking.
Thank you. Thank you. We'll conclude the session.
Thank you, sir.
Good job.
We'll proceeding to now next session, clinical trials by Dr. Pradeep Narayan, sir.
Morning, everyone. So, as you know that I was supposed to talk on clinical trials, but then Shukla sir said that why don't I talk about how to read clinical trials. So it's rather than giving you a fish, why don't I try and help you catch a fish so you can figure it out for yourself. Okay. Right, so what I'm going to do in this talk is I'm going to talk about some very simple concepts, and depending on how much time we have, I might talk about some tips about data interpretation as well. Do we have a timer anywhere? Otherwise I can keep my own timer. Okay. So now if you look at the screen, you have got certain terms. Odds ratios, hazard ratios, relative risk, and it's quite confusing as to why sometimes we read odds ratios, sometimes hazard, and sometimes relative risk. Then yesterday Dr. Vinita showed you some graphs. Usually when the graphs come, it looks very beautiful, but you tend to skip it. And she also showed you the forest plot, which I'm sure a lot of us just skipped through. These are not very difficult things to understand, and I'm hoping that if you just listen to me for the next 10-15 minutes, you will walk out of this room able to interpret all of them. You also come across three terms. This is the exact page that I have taken from the ART trial. Now if you look at your screen, it says per protocol analysis, intention to treat analysis, as treated analysis. How can the same paper, same randomized control trial have three different analyses, and why? And by the way, those of you who are appearing for your exams, intention to treat analysis came as a short note as well. So, two reasons why you should listen to me, if you didn't have another reason. So to understand what these three types of analysis is, let us imagine a study that we are conducting. We are comparing beta versus zeta. Our sample size is 12, so 6 of them will have beta, 6 of them will zeta. This is how we think it's going to look, or it should be looking. Now as happens, not all of us are very good, especially me, harvesting the REMA. Let's say that I damage the REMA in 2 cases. Now we have a situation where the beta group, 2 patients had only single mammary. So this is what the cohort looks like. Now the problem we have is, in the zeta group, all of them had a single graft, single mammary. But in the beta group, we have got 4 patients who had bilateral mammary and 2 had single mammary. Now, how do we compare these 2 groups? Because, how do we do it? Because one group has got a mixture now. So one option is, we simply remove these 2 patients. So we have got 4 patients, 4 betas and 6 zetas, simple. This is what our protocol was, that we'll compare beta versus zeta, and because this was our protocol, this is called per protocol analysis. Very simple. What is the other option? Other option is, because they had single mammary, you simply shift them to the other group. Once again, you have got beta in one group and zeta in one group. Now, unlike the previous group, if you remember, we had removed 2 patients. What was the problem there? Now our sample size, which was 12, was only 10. Here the sample size remains the same, 12. What is the problem? You have got 4 patients in one group and 8 in the other. So this is called as treated analysis, because 2 patients got treated with single graft, single mammary, so you moved them to the other group. Now third option. Now let us assume that the 2 patients who are supposed to have beta, let us pretend that they actually had beta, even though they had only had single graft. So because we intended to treat them with bilateral thoracic artery, we'll assume that they actually got a bilateral thoracic artery. This is called intention to treat analysis. For a randomized control trial, I don't know what you think is the best type of analysis. You'd intuitively think that intention to treat is the worst one, because here you are pretending that 2 people actually got bilateral mammary when they only had one. But statistically, that is the most powerful analysis. Intention to treat is the most powerful analysis compared to per protocol or as treated. The reason being, it includes all the patients and it maintains the randomization. So I think those 3 concepts are pretty straightforward and simple. Now we'll come to 3 terms that drives everybody crazy. Relative risk, odds ratio, hazard ratio. So relative risk is also known as risk ratio. I've already shown you this. Let us just try and figure it out what they are. Okay. We'll ignore this for the moment. So again, to understand this, let us assume that we are doing a study where we are comparing the post-operative renal impairment between CABG and PCI. So what is relative risk? It's nothing but probability of people developing renal impairment after CABG divided by probability of renal impairment after PCI. Probability. Concentrate on the word probability. What is odds ratio? Exactly the same, except probability, it is odds of developing renal impairment divided by odds of developing renal impairment in CABG. So the difference between relative risk and odds ratio is the term, probability and odds. Now English is a very funny language, as Amitabh Bachchan has told, because if you look at the synonyms in the dictionary, probability and odds mean the same thing. But when you think mathematically and statistically, they are different. So to understand this, let us assume that 1,000 patients underwent CABG, of which 300 developed renal impairment. So what is the probability of people developing renal impairment after CABG? Simple. Those who developed renal impairment divided by total number of patients. So that's 300 by 1,000, that is 0.3. What are the odds? Slight difference. Those who developed renal impairment divided by those who did not develop renal impairment. So instead of 1,000, now the number is 700. And the odds ratio is 0.42. So you can see that the odds ratio is always higher than the risk ratio or the probability. Now when we compare 2 probabilities, it's a relative risk. When we compare 2 odds, it's odds ratio, as simple as that. Okay, I hope that clear. But there was one more term that I mentioned, that is the hazard ratio. So hazard ratio is nothing, but it's exactly the same as relative risk over a period of time. So when you say that what is the chances of somebody having a MACE event in 5 years, you are talking about hazard. You are not talking about relative risk. Relative risk and odds ratios are instantaneous, so time is not a factor. But whenever you add time, it becomes hazard ratio. I hope I haven't lost you so far. How do you interpret them? Well, it's simple. It's almost like, so silly, it's a class 2 mathematics. If the ratio is more than 1, the risk is higher. Ratio is less than 1, the risk is lower. If it's 1, there is no difference. That is how simple it is. Now let's take a look at this table. Now we all know p-value, less than 0.05 is significant. But most journals these days don't provide you with p-values. They provide you with odds ratios and confidence intervals, or hazard ratios and confidence intervals. So you have to learn to interpret based on the odds ratio. Now I've already told you that odds ratio, if it's more than 1, the risk is higher. So here you can see the risk is higher, isn't it? Risk is lower. risk is higher, but risk is higher or risk is lower, but is this statistically significant? Anybody wants to take a guess? If the 3 arrows show a statistically significant result, all right, I'll tell you then. So when the odds ratio, look at the odds ratio and the confidence interval. Odds was 0.63. Confidence interval was 0.41 to 0.96. Interpretation is, so the odds ratio is 0.63, the risk is lower by 37%. When odds ratio was 1.96, risk is higher by 96%, so almost double. And 1.19, the risk is higher by 19%. Look at the bottom confidence interval, that is the key. If it includes 1, it is not a significant value. If it does not include 1, it is significant. So the first one, you can see it includes 1. So this is higher, but statistically not significant. If you look at this, it is lower, and it is statistically significant because it does not include 1. And I'll let you guess this one. The risk is higher, lower, anybody? Higher. Yeah. And statistically significant or not? Significant. It does not contain 1. Now look at this chart. Suddenly it looks, easy. It makes sense. So this is higher, statistically not different, lower, significant, higher and significant. These are significant, these are not significant. Now, Dr. Vinita yesterday showed you another graph, which I thought was actually very simple, the Kaplan-Meier curve. Now, here you can see the p-value is not given. I mean, it's given, but I've hidden it. But you can make out looking at it, if the MACE rate is higher, 28.4% compared to 19. But is it significant? Can anybody say, looking at the confidence interval?
Yes, sir. Yes.
Significant?
Yes, sir.
Okay, let's check with the p-value. P-value is highly significant. So now we know two ways of judging significance, by p-value, which you all knew, and by the odds or the hazard ratio and the confidence interval. Confidence interval does not include 1, it is significant. I'll tell you a third way, which is unique to Kaplan-Meier curves. So this is a Kaplan-Meier curve I think Dr. Vinita showed. This might have been the exact figure. But most of the modern journals, they'll give you this figure. What is that shaded area? That is the confidence interval. If the confidence interval, if the shaded area overlaps, it is significantly not different. Or rather, I would say 5% overlap is allowed because p-value is 0.05. So there might be slight overlap, but if there is significant overlap or large overlap, it is not a statistically significant difference. I'll show you the picture from the RAPCO trial. So they compared radial artery with Rita. Now look at the overlap. There is very slight overlap. So I think this is a significant difference. Now let us check. Look at the hazard ratio. The confidence interval does not include 1 and the p-value shows 0.01. So we now know 3 ways: p-value, confidence interval, and the overlap between the shaded area of the Kaplan-Meier curve. And just to give you another flavor, look at this curve. What do you think, just eyeballing it? Do you think there is significant overlap between the top and the bottom color? I think the answer is yes. I'll draw it for you. There is a huge overlap. Look at the confidence interval. It includes 1 and the p-value is 0.05. So that is not significant. 0.05 is not significant. If it's less than 0.05, it's significant. So what are the key things to remember? If it contains 1, there is no difference. If there is no overlap, there is definite difference. And if there is overlap, depends on the degree of overlap. Now I'm quite flattered by all of you taking pictures, but anybody wants this presentation, you are welcome to have it. You just have to write to me or to Srikanth. He has got a copy as well. Now I know statistics and clinical trials are very boring, So I've got a little bit of entertainment for you as well. Look at these 6 cards and choose one, okay? Any one. Have you chosen your card? I'll choose it again. Still there? Your card is still there? All right. Now what I'm going to do is I'm going to make that card disappear. Has your card disappeared? If it has, feel free to clap. Thank you. I'll tell you the trick later on. But now, now I'll come to forest plot. Okay? Now this looks pretty scary, but actually, you know, believe it or not, it's the simplest thing on earth. So again, I'll have designed something for you. So this is my forest plot, okay? There are 5 studies. You just need to understand what the different parts mean. So if you look at, so we are comparing again beta is better or theta is better for whatever, say, you know, wound infection or whatever. So what does this show? This box shows the number of participants, that is the sample size. Nothing there is by chance, everything has a purpose. What is this line? This line is the confidence interval. Now, take a pause. What number should be included in the confidence interval to make it not significant? 1. Fantastic. So this is called the line of no effect. So if the confidence interval touches that line, it's a line of no effect. What number should it have? 1, as you all guessed. So it's the same principle, you know, time and time again. All statistical analysis follows the same principle. Now let's look at this. These 3 are not touching the midline. So they do not include the number 1. So there must be significant studies. These 2 are touching the midline or crossing the midline. So they include the number 1. So these studies show non-significant results. Now this is usually done when you're carrying out a meta-analysis. So you have a sum total result of all the different studies, and you get what is called the pooled effect. There is a diamond at the bottom. Now I have a liking for single memory. I'm not a bilateral memory person, so I have shifted the diamond purposely to the theta side. But that might not be correct. That's just my bias. Okay. There is something called I2. This is the only other thing you need to understand in forest plots. This stands for heterogeneity. What do we mean by that? What we mean is how close are these results to each other. So all these 5 studies, how different are they from each other? Higher the heterogeneity, worse is the result. Worse is the reliability of the result. So it should ideally be less than 40%. Definitely not over 50%. Here I have purposely put it as 29%. Now you look at this complicated forest plot. You can identify, you can go through each and every one. This is the 4th way of understanding significance. If you look at each study, those black boxes, they represent the number of patients. If you look at the hazard ratio, you can say whether it's higher or lower. If you look at the confidence interval, you can say whether it's significant or non-significant. And on the right hand side, there is something called weight. So don't have to worry about the weight. Weight only means what is the contributions in the entire meta-analysis, how many patients have been contributed by that particular study. Because visually it might be sometimes difficult when you have so many different studies to differentiate which is the largest study, which is the smallest study. That's forest plot for you. Okay, and that's a pooled effect, and that is heterogeneity. You can see it's written, every forest plot will have a pooled effect and a heterogeneity. So those are the only things you need to know. Okay. Now, as I said, statistics can get very boring. So we'll now go into a little bit of data interpretation and some of the terms that we use, but I'll show you a picture first. Okay. What colors do you see on your screen? Anybody? It's not a difficult question, just please answer. Gray and darker gray or black or whatever. I want you to take 2 fingers in front of your eyes and try to block the junction of those two. What do you see now? They are the same color. Now I have not touched anything. I have not done anything. Okay? For those of you who could not get it, I'll block the junction. Look at these two orange circles. Which one is bigger? It's a trick question. Everybody knows it's the same, isn't it? It's because it's called Ebbinghaus illusion. Now, I had an omelette this morning, so I thought I'll put this picture up. Do they look same or different? Same. But there are a lot of differences. Look at this picture. They look the same. But obviously, it's like, I don't know if you people had the opportunity to read a magazine called Chanda Mama, but I think some of us may have read Chanda Mama. You had to spot 10 differences. Okay? There are more than 10 differences here. Now, we have just understood two important statistical concepts. One is this: when we saw a difference, when there was no difference. Okay? That is called a type 1 error. That is a type 1 error. The second case, we didn't see a difference when there was a difference. That is called type 2 error. So this is, actually there are other terms for this. It's called false negative and false positive. The first one was false positive. This one is false negative. Do we have time for another 5 minutes? 5 minutes. Okay, sir. So I'll tell you, there is a big confusion about mean and median. And most of the theses that I see, so what students do is they get it from the statistician. The statistician gives you mean, median, standard deviation, interquartile range. Every possible analysis is given, and the students copy and paste it. Nobody understands. I'm not even sure if the person who is reading the thesis from the DNB board also bothers to read it. But everybody goes through it, copying and pasting without understanding what we are doing. I'll try and make you understand why mean and median are different. I won't ask you for the definition. Now let us assume that we are comparing minimally invasive CABG with PCI. Okay? Now if I say that the length of stay after CABG was 5.85 days and after PCI is 2.95, where do you think the stay is longer? PCI or CABG? Any confusion? CABG. Everybody agrees? Now, if I say the median length is this between CABG and PCI, where is the stay longer? Median is the same. So, can we conclude that length of stay is the same? Now is the interesting part. This is the same data. It's exactly the same data that I have analyzed. This is a real life data. When you analyze, when you look at the median, it looks like that CABG is longer. When you look at PCI, the median, it looks the same. Why is that? It's because of this. When you plot, see, when you have a normal distribution, so when your data follows the, what we learned in preventive and social medicine, a bell curve, it's called a normal distribution. It does not matter whether you measure mean or median. But if the data is skewed, so after CABG, say everybody went home around 5 to 6 days. There were 2 guys who went on day 40 and day 60. Now they have completely destroyed the data. Look at the outliers. They are called outliers. So I don't know if anybody has read the book. I know Devashish has, by Malcolm Gladwell. Yes? You have a question? No, you have read the book. Very good. I'm impressed. Now, tell me one thing. If you were to read this paper, where it says the length of stay after a CABG was, a mean was this, and after PCI was this, would you worry about this? And if yes, why? If no, why not? I mean, if I look at this, I know that this data is fabricated. The clue is in the standard deviation. Every time the standard deviation is higher than the mean, only 2 things can happen. A, either the data is skewed when they should not have calculated the mean, they should have calculated the median, or they are lying. Both can happen. So let us get out of this. Now, we all know that with mean we talk about standard deviation. What about median? When we say median, there should be something else with that. That is called interquartile range. I think again this was shown yesterday by Dr. Vinitha. This is called a box plot or box and whisker plot. And this is the box, these are the whiskers. Simple. What does it represent? So there are 4 parts. The number 2 is the median. So remember, the median has to be inside the interquartile range. Okay? If the median is not in the interquartile range, either your analysis is wrong or the data is fabricated. And believe it or not, that's the end of my talk. Thank you very much for listening. Any questions? Okay, all right. Thank you very much.
Thank you, sir, for this excellent talk. So this next topic is IABP by Praveen Murma, sir.
Can you have a slide here? So I'm going to talk about IABP. It's important from the exam point of view as well as from the practical point of view, because when you're going to put an IABP, most of the time the indication to put an IABP, weaning from IABP, troubleshooting, all of this has to be done by the cardiac surgeon. So we need to know most of the things about IABP, and I'm going to cover it in next 15 minutes or so. So this is how I frame my talk. Always, start with history. Then how does this IABP work? What are the indications for IABP? What are the contraindications? You have to know the console. What are the triggers for IABP? What are the particular waveforms you see, and how will you interpret it? How do you insert this IABP, and what are the complications of IABP? So history, always, people say two guys' names. One is the Kandrovix and the other one is Maulopolos. So Kandrovix is the guy who actually gave the concept that a balloon or something that augments the diastolic pressure increase the coronary flow. So the concept came from Kandrovix, and IABP was actually, the development, the experimental prototype was made by Maulopolos. But insertion, the first insertion of IABP was done by Kandrovix again in 2 patients with cardiogenic shock, and 1 died. 1 patient survived. So if you're asked in the exam, who developed IABP, you have to say 2 names, Kandrovix and Maulopolos. Kandrovix gave the idea, and Maulopolos did the experimental prototype, and Kandrovix again did the first insertion. So these 2 names, Kandrovix and Maulopolos. The percutaneous insertion came in late. It came in 1980s. Before that, it was an open insertion. So the percutaneous insertion of IABP started in 1980 by this guy called David Breckman. But you can forget this name. Second part is, how does it work? So the answer is 2 things. 1, it causes a diastolic augmentation of pressure. So it improves the coronary blood flow. That is the first thing. In diastole, it inflates, the balloon inflates in diastole, so it increases the coronary blood flow. And just before systole, it deflates. So it reduces the afterload. When the afterload is reduced, the heart functions much better. The stroke work is decreased. The systolic or the stroke volume is increased, and the end diastolic pressure is decreased. So when there is a decrease in end diastolic pressure, there is an increase in ejection fraction or stroke volume, and there is an increased coronary blood flow. What happens is that it decreases the demand to the heart, and it increases the coronary blood flow and increases the cardiac output. So this is the basic mechanism. So in diastole, it augments the coronary blood flow, and in systole, it augments the cardiac output and decreases the workload of the heart. I hope this concept is clear. So this is the mechanism of action. So it is used as a bridge to recovery or a definitive treatment, increases the diastolic pressure, improves the coronary perfusion, decreases the afterload, and increases the cardiac output. So this is that curve that gets shifted out. So the left ventricular end diastolic pressure comes down, the stroke volume increases, and it reduces the myocardial oxygen demand. So what are the indications? The indications are, of course, any patient in cardiogenic shock, high-risk PCI. If the patient has got a lot of complications where the cardiologist thinks that it may crash, you can put an IABP to support the PCI. Myocardial infarctions with mechanical complications. These patients are in extreme cardiogenic shock. These patients with ventricular septal rupture, patients with papillary muscle rupture or free wall rupture, these patients IABP is useful. Any patient who develops low cardiac output after cardiac surgery, you can place an IABP, or it can be used as a bridge to treatment in patients with the following conditions like intractable angina, because it increases the coronary blood flow, it improves the myocardial oxygen supply and reduces the myocardial ischemia. Any patient with a refractory heart failure or intractable ventricular arrhythmias. These are the classical indications for IABP. What are the contraindications? So there are two major contraindications where it is absolutely contraindicated. These are patients with severe aortic valve regurgitation or patients with an aortic aneurysm or aortic dissection. But it's not contraindicated, but it's probably not useful in patients with uncontrolled sepsis. You have to be very careful in patients with a bleeding diathesis, or it may be difficult to insert in patients with a peripheral artery disease. So if you are asking the exam, what are the absolute contraindication, you should say severe aortic valve regurgitation or presence of a DTA aneurysm or aortic valve dissection. And it's not useful in sepsis or septic shock. You need to know the console. So these are the marker here. These are the console you will see. First is the ECG. That is the trigger. That is the usual trigger used. Then after that, you will find two blood pressures. The systolic blood pressure, diastolic blood pressure, and then the augmented pressure. And then you need to know what is the trigger. So there are several triggers. One is the ECG. Second is the pressure. Third is the atrial pacing or atrioventricular pacing, and then the internal mode. And you need to know the back of this. So that is the helium. That is the gas that is used. That is the helium. I'll come to this later. So what is the trigger? The trigger is the point or the indicator that is used for timing the inflation and deflation of the balloon. So commonly what we use is the ECG trigger. On ECG, it is timed ideally with the systole, or the inflation is timed with the T wave. That is the beginning of diastole, and it is deflated at R wave. Understand this very carefully, that it inflates at T wave, that is the beginning of the diastole, and deflates at R wave. But most of the time, the T wave may not be very clear in the ECG. So all these new IABP machines, they actually time the inflation with the R wave. It may look paradoxical that it is inflating with R wave. It is not inflating with R wave. It is actually timing the deflation with R wave, and with an algorithm, it is inflating at the beginning of diastole. Did you get it? So R wave is the most prominent wave seen in the ECG, and this is used to time the deflation, not the inflation. And with an algorithm, they will inflate at the beginning of T wave. So R wave, so in the exam, if you asked, what is the timing of this one? Don't say R wave, say that inflation is timed with the T wave, deflation is timed with the R wave, but because T wave may not be clearly seen all this uses an algorithm to deflate at the R wave, so automatically it inflates at the T wave. I hope I got it. Second trigger is the pressure wave. So pressure wave is that if the ECG is not available, or it's an emergency, you did not connect the ECG, then you can time it with the pressure wave. So when will you time the inflation with the pressure wave? Just before the dicrotic notch. So dicrotic notch is where the aortic valve closes. Just before that, if you time the inflation, then it becomes a diastolic augmentation. Then there are other things which called as the AV, when the patient is in AV sequential pacing, like demand pacing, then the V wave of that pacer is considered as the trigger. And if it is atrial wave, it is still the R wave. So when you put the patient on atrial pacing, you will find a tail where the atria is going to give the impulse. What this console does is that it actually eliminates that tail and uses the R wave as a timer for deflation. I hope you understand that. And fifth one is the internal mode. So this internal mode is that the IABP automatically inflates and deflates at around 80 beats per minute, and it is used during only 2 times. One is at cardiopulmonary bypass. There is no ECG. It gives inflation and deflation during cardiopulmonary bypass, so that it gives some pulsatile flow. Or during cardiac arrest, when you put this one, there is no ECG, there is no pressure, but it inflates and deflates at 80. So these are the 5 modes. Trigger, that is the ECG, pressure, AV pacing, atrial pacing, and 5th one is internal mode. I hope I am clear. Then you understand the waveforms. So in exam, if you are asked, is the IABP working? Then you say that IABP is working only if you keep the IABP in 1 to 2 or 1 to 3 mode. In 1 to 1 mode, you should never say that the IABP is working well. That is because you need to look at 2 pressures. One is the assisted diastolic pressure, and another one is assisted systolic pressure. So if IABP is working, the assisted diastolic pressure and the assisted systolic pressure will be lower than unassisted diastolic pressure and unassisted systolic pressure. So if you have an assisted pressure, the end diastolic pressure will come down. Then the next is the assisted systolic pressure. So it has to start inflating from a lower portion, so the assisted systolic pressure will be lower than the unassisted systolic pressure. So always put the balloon in 1 to 2 or 1 to 3 mode before you make that decision that, okay, this balloon is working well. So if the balloon is working well, again I am repeating, assisted diastolic pressure and assisted systolic pressure should be lower than unassisted systolic pressure and unassisted diastolic pressure. And second is, you need to have a proper V form between the systolic and the augmented pressure. So if these 3 things are met, that is a proper V form, and assisted diastolic pressure is lower than the unassisted, or assisted systolic pressure is lower than, then you say that IABP is working well. So you interpret the readings. First is the ECG. Can you see a mark there? That is, it is now timing the inflation with the T wave. That is diastolic. Second is, you find, you have put up this one on 1 to 2 mode, and you have all this pressure. That is assisted, unassisted, assisted diastolic pressure and unassisted diastolic pressure. Always remember that assisted systolic pressure should be lower than unassisted systolic pressure, and assisted end diastolic pressure should be lower than unassisted end diastolic pressure for the balloon to work. Then you will see something on the lower part that is called as the inflation pressure. So that is the timing of the inflation. There is a balloon, the helium is going into the balloon and inflating. So it has to be 100%, and that is the augmented pressure that comes. Then the lowest one, you will find that the helium, how much is helium is left, and whether the battery is fully charged. So this is the console you have to know. So always, once you place the balloon, place the patient on 1 to 2 or 1 to 3 and see that all these parameters are met before you start the balloon further. So again, the same thing, all this IABP waveforms you have to interpret. Yeah, so again I'm saying, so when the balloon inflates, that is called as the inflation timer. It has to be just above the dicrotic notch and has to deflate just before the R wave or just before the next systole, and the end diastolic pressure will be lower. So there are a lot of timing errors. I think Vinita showed yesterday. So there is basically 3 timing errors can happen. One is, what is the first one? It is early augmentation. That is just after the systole, before the dicrotic notch, just at the systole, or just at the time of systole, it is augmenting. What will happen if the balloon augments at systole? Afterload increases. There is a heavy increase in afterload. So the heart will fail. What is that one? Second one? You see that it is late? Yes. How did you know that it is happening after you can see the dicrotic notch, and it is inflating after the dicrotic notch, and the augmented pressure is less than the systolic pressure. That means it is late inflating. What is the last one? This one? What? Late deflation. Look at that. It is deflating just at the R wave, or it's just before the next systolic wave. So end diastolic pressure, look at the end diastolic pressure. End diastolic pressure will not be lower than the normal end diastolic pressure. So it's a late deflation. That also is going to increase the afterload of the heart. While what is this third one? Early deflation. So when early deflation is going to happen, it is not going to reduce the end diastolic pressure. So these waveforms you will have to know. So basically, always look at put to 1 to 2 or 1 to 3 and see all these parameters. Again, I am saying that assisted end diastolic pressure and assisted systolic pressure should be lower than the unassisted ones. If it doesn't, there is a timing error. So these are the timing errors and what are the problems that can happen in timing errors. Do I have time? So how will you size the balloon? So sizing of the balloon is by height. If you are less than 162 centimeter, you take a 30 cc balloon. 162 to 182, you take a 40 cc balloon. And if it is above 182, you take a 50 cc balloon. That is very simple. And how will you set up? See the video. The first thing is to, if you are asked in the exam or in the practical this one, first thing is what you have to do is to attach the ECG leads. That is the first thing. And that has to be connected to the back. And ECG has to come properly. You need to have a proper R wave. And if T wave is there, then that's okay. So that is connected. That is the first thing. You connect the ECG. Second, you have to know the kit. You have to open the kit. So kit has 2 components. One is the introducer sheet.
The balloon catheter tray contains the balloon pump components.
Yeah, this is, I think I can stop the sound. So what kind of IABP is this? Can anyone say? There's a cable attached. Anybody? Yeah, fiber optic. It's a fiber optic IABP. So that is a fiber optic IABP, this one. So there are 2 types of balloons. One is the fiber optic, where you find a cable attached. Other one is the pressure transduced one. where the tip of the IABP, that there is a hole through which pressure is transduced. So both are there. Fiber optic is a little more expensive than the fluid filled, but it is supposed to, fiber optic is supposed to be better especially in patients with arrhythmias, atrial fibrillation or ventricular tachycardias. It senses much better. So these are the two types of IABP balloons. Third is you are going to insert the IABP. This is the most important thing in IABP, is that if you have a false insertion, the chance of leg ischemia is very high. It's around 12.5%. So you need to know where to introduce the IABP. In cath lab, the cardiologists insert the IABP by two things. One is that they look at the femoral head. The femoral head is their, the head of the femur is their point. They introduce the needle puncture is at the femoral head, and then ideally it has to be between the inferior epigastric artery and the superficial femoral artery. So if you go little above that, you go above the pelvic brim, and if you have a counter puncture, you are going to have a retroperitoneal hematoma. How in, we don't have a cath lab or fluoroscopy facility in the OR. So how will you do is, you can use an ultrasound if it is there to do it. But most of the time, the patient is not coming off bypass. There is no pulsatile flow. So one simple trick is that you draw a line from the anterior superior iliac spine to pubic tubercle. That is the first oblique line. And then you make another transverse line from the pubic tubercle like this and hit in between. Most of the time, you will be in common femoral artery, below the pelvic brim and above the superficial femoral artery. I hope you understood this. So draw an oblique line, that is the inguinal ligament. From the anterior superior iliac spine to the pubic tubercle is the inguinal ligament. And then draw one transverse line from the pubic tubercle, hit in between. You will be in common femoral artery. So insertion, if it is not proper, it can cause retroperitoneal hematoma. If you go for a low insertion in superficial femoral artery, it can occlude the superficial femoral artery and can cause leg ischemia. So this is the various methods. And see the insertion. So it is hit at 45 degrees, and then you insert a guide wire. Ideally, you should have a TE, transesophageal echo, to see that it is below the left subclavian artery, and this is the dilating sheath. So always remember that the dilating sheath should follow the guide wire. If you don't follow the guide wire, dilating sheath can injure the femoral artery and can cause retroperitoneal hematoma. So this is a mannequin. So you dilate. Then see that the guide wire is repositioned below the left subclavian artery. Then you deflate the balloon. How many of you have placed on IABP? Good. So all of you are experts in IABP. Yeah, that is the thing that is connected to the helium. Flush the catheter. Then take it from the sheath. Then follow the guide wire. So there are two ways of inserting. One is using a sheath, and another one is using a sheathless one. So we usually go by the sheathless one because the insertion of IABP through sheathless method reduces the limb ischemia by less than 2% of the time. So once the IABP is placed, you start the IABP, and then you will start seeing the pressure sensors. Choose usually an auto mode and trigger as ECG, because ECG is well seen. And then augmentation, you keep it as 100% and start the balloon. And then first you will see the inflation of the balloon by the helium. That is the helium, it is filling, they will say the auto filling. It is going to fill the balloon, and then you can see that chair-shaped, the chair-shaped thing is coming. That means that the balloon is inflating. So why helium? Another question that is asked. Because helium, answer should be helium is inert and it has a very low density so that the shuttling speed is very fast. So these are two answers. Inert and shuttling speed is fast. And how much of balloon should occlude the aorta? It should not occlude more than 90% of the aorta when it inflates. So these are the complications of IABP. The most common complication, if you ask, it is the leg ischemia. And alternate sites of insertions are also there. That is, if femoral artery is not accessible, or if you want to have an ambulant patient, you can use axillary artery as an alternate site of insertion of IABP. And you need to know the various, the timing and the inflation errors. So I have a short quiz for you. What is the ECG trigger for inflation and deflation in IABP? Yeah. Inflation is at T and deflation is at R. What is the alternate sites of insertion? Axillary artery. What is the absolute contraindication for IABP? Acute aortic valve regurgitation and aortic aneurysm or dissection. Is it useful in septic shock? Is it useful in septic shock? Yes or no? No. Why not? Septic shock, there is no very low diastolic pressure. So it's never going to augment. So it is not at all useful in septic shock. Is it useful in hypertrophic obstructive cardiomyopathy? It's a tricky question. Is it useful in hypertrophic obstructive cardiomyopathy? What does balloon cause? It reduces afterload. What will happen in hypertrophic obstructive cardiomyopathy if you reduce afterload? It worsens left ventricular outflow tract obstruction, isn't it? It worsens the systolic anterior motion. So it's not useful in patients who have dynamic left ventricular outflow tract obstruction. Because dynamic left ventricular outflow tract obstruction, the treatment is to increase the afterload. IABP is going to reduce the afterload and worsen it. What about anticoagulation? Is it needed or not needed? Needed. There is no consensus. Absolutely no consensus. Some people give it, heparin. Some people don't give it. There is no consensus on anticoagulation. And what is the most common complication of IABP? Leg ischemia. I think, thank you. Any questions? Again. I hope I'm stuck on time.
Thank you, sir. There is one small case presentation also. Yes, yes. One more case presentation. Dr. Beju, sir. May I invite Dr. Beju, sir? Dr. Devashish Das, sir. Please, sir. Dr. Shukla, sir. And Jayant. Rashekar sir, please you come, sir. Dr. Saurabh Gupta, please come fast. The case should be short case only, the relevant findings, investigations, and sir will discuss about the course and the steps, because already tetralogy discussed. And it,
Okay, you can tell us the diagnosis.
Good afternoon, teachers. So my diagnosis for today case was
Age of the patient first.
Yes, sir.
Age.
He
and
was a
weight and then
24-year-old. He was a 24-year-old gentleman, and he presented to us with cyanosis since 1 year of his birth, and easy fatigability 1 year after the birth. History of presenting illness.
No, where you tell us the diagnosis. I think
Yes,
we
sir.
can.
So our diagnosis for this gentleman was he was a cyanotic heart disease with reduced pulmonary blood flow, most probably tetralogy of top physiology, with signs of CHF.
Never use abbreviation. You have to use the expansion only.
Sir, tetralogy of Fallot physiology, with signs of chronic heart failure, but no signs of infective endocarditis.
Okay. Why are you saying that it is a heart failure?
Sir, because he presented us with a pedal edema, and he has severe dyspnea on exertion. Initially, like around when he was on age of 12, he had started these symptoms, and when that time he was on NIHAS 2. Now it has been more severe. DOE has been more severe on recently 6 months now, sir.
What are the causes of heart failure in a case of tetralogy of Fallot?
Sir,
the causes are, first one is anemia. Second is if there is MAPCAS or PDA, if there is aortic regurgitation, if there is restrictive VSD, that can cause RV failure. These are all causes of heart failure, sir.
What else?
Top with absent pulmonary valve syndrome, that can cause PR and heart failure.
What else?
So shunted off, post-BT shunt off can present as heart failure.
What else?
Top with hypertension and aortic regurgitation can present with LV failure.
Right. So that might be just a question. I think we discussed the entire part yesterday, so we'll start from where we left yesterday. Now we finished the surgery part yesterday. So now we are trying to come off bypass, and again the same question like we discussed the AVR part, so you're not able to come off.
I want to engage all of you. You please come forward. Okay.
Finished a tetralogy repair. It's a patient underwent intracardiac repair with a short transannular patch, and you're not able to come off.
1 second. Let me ask one question. What are you aiming by repairing a tetralogy? What are your aims, your targets?
Sir, please repeat the question.
What is your target when you are repairing a tetralogy of Fallot? Can you hear me?
What is your target in repairing a tetralogy? What are the things that you're addressing surgically?
So for surgery, are you asking about, sir? Yeah. Sir, the ultimate aim for repairing a top physiology that we want to, the obstruction we want to relieve, we want to equalize.
No. The ultimate aim of operating a tetralogy is to eliminate the right to left shunt. Okay, ultimate aim of, but you want to get it at the lowest possible right ventricular pressure. I cannot go and close the ventricular septal defect and leave it like that without relieving the RBOT. That's what I was explaining to you yesterday. So when you are closing that shunt, you have to provide an alternate pathway. So the ultimate aim is to eliminate the right to left shunt with the lowest possible right ventricular pressure, lowest possible in inverted commas. If you try to achieve very low pressure, you will end up with a different problem. That I will come to that later. Okay. And the secondary objective is to preserve the pulmonary valve function when possible and preserve tricuspid valve function as much as possible. Okay. You clear? So you are operating a tetralogy to eliminate the right left shunt. At the same time, you have to avoid RV hypertension, preserve the pulmonary valve function when possible, and maintain the tricuspid valve function. Okay.
So I'll just summarize what he is trying to say is there are two main purposes for tetralogy repair. One is to establish adequate pulmonary blood flow. Second one is to ensure that the pulmonary vasculature is under low pressure, which will not burden the RV. Evolutionarily, the RV is a volume ventricle. It is not designed for pressure handling. So the pressure in the pulmonary vasculature should be low. And there should be ensuring adequate pulmonary blood flow. If these two objectives are achieved, all that secondary objectives will be fulfilled.
Okay,
so
now we can
you're not able to come off. Let's address that. About adult
sir, we can divide in two causes. So first one is metabolic causes. Maybe there is hypothermia, maybe there is hyperkalemia, acidosis, and
basically standard checklist of inability to come off unrelated to tetralogy, which would apply like we started for the AVR. So whether you're warm enough, whether you have a proper rhythm. So that is for these questions will be in various scenarios. First is a standard checklist which Dr. Rajshekar illustrated in the AVR case. That applies for most of the patients who would undergo a on-pump procedure.
So mechanical causes like residual shunt will be there if there is residual VSD. Second is if there is collaterals or PDA, if we left it, then there can be, we cannot pump, off pump. And
sir, post VSD closure, there is systolic anterior motion of the septum, so it is occluding the left ventricular outflow tract.
Oh, there is an entity like that?
No, that would be like, I don't know.
No, no, it's touching your imagination too much. Ventricular septum cannot go systolic anterior motion produce left ventricular outflow obstruction. If there is an outflow obstruction, that's because your patch is not good. Your patch is too short or too small and is bulging into the LVOT. The septum doesn't bulge. Please have your concepts right. Okay. Septum doesn't bulge.
Go with the more common reasons first.
So,
not even common, it does not happen.
So what I have told you, your aim is to close the VSD with the lowest right ventricular pressure. So the simpler, and you have a trouble, you have to identify where the trouble is. Okay. These days, all of us have echo in the room, but imagine a situation, you are in a small place where there is no echo. You have the heart in front of you, you have a transducer, you have a needle. Okay. So with these things, how do you identify whether you have achieved your target? Understand? So I need to catch a flight, so I'll be I'll be very short. So you check the PRV LV. Okay. What is the relationship between the normal RV and LV pressure?
Less than 1.8.
Normal.
No.
Normally,
so
what
less
would
than
be the pressure
0.5.
in the LV and what would be the pressure in the RV normally? So the LV pressure is very high. The RV is not a pressure ventricle. It will be less than 1/3. Okay.
RV has to be normally less than 1/3. Okay, then, but we are not trying to achieve that normalcy. I'll tell you the reason later. So what is acceptable is that you have to have an RV of around 0.6 or 2/3 of the systemic pressures. Okay, suppose you have a problem in coming your bypass and you're checking your RV pressure is more than 2/3. No, understand? Now what could be the problem? Where is the problem? There could be lot of problems. Everything is precipitating as an increased RV pressure. Okay. One is that there is an outflow obstruction, or there could be a obstruction at the annulus, or above the annulus, at the branch pulmonary artery, beyond the branch pulmonary artery, and some other reasons. So how will you do the differential diagnosis? Where will you check the RV pressure? Which part of the right ventricle? No, you try to check the most proximal RV pressure, which is somewhere around the inflow or below the infundibulum. The reason for checking at the inflow is that you don't miss any leftover obstruction at the infundibulum or what you call a low outflow obstruction. Okay, so that pressure is high. Now you know that you have an issue. You have not achieved your hemodynamic target. Now you need to figure out where is the obstruction. What is the next thing you will do? You check above the annulus. Okay, so suppose there is a gradient there. That means there is an obstruction from the inflow to the annulus. So it could be anywhere. It could be in the low infundibulum, it's at the annulus. Now what will you do? You check immediately under the annulus. So there is no gradient between inflow and the outflow, and there is a gradient between the outflow and the main pulmonary artery. Your problem is at the pulmonary valve. If you preserve the valve, then you have to enlarge it. Okay, then I'll tell you that your PRV is high, and you check these three places. There is no residual RV outflow obstruction. Now where could be the problem? It could be, if you put a patch, it could be at the distal end of the patch, or could be in origin of any pulmonary artery. Okay, now what will you check? So in that situation, your RV pressure and main pulmonary artery pressure is same. Now where will you check? You put a transannulus patch up to the confluence. Now you check at the branch PA, and especially you check the right pulmonary artery. Left is not easily accessible. You check the right pulmonary artery, and if there is a gradient from MPA to the right pulmonary artery, there is a distal obstruction, which you have to correct. Okay. Now the next problem is that you check the right pulmonary artery, that's also high. Now what will you do? What could be the problem? What are the possibilities? What is it called? Peripheral pulmonary stenosis, where your LPA, RPA pressures are high, and there is no obstruction downstream. Now we have to go distally. You have got one is peripheral pulmonary stenosis. Can anything else produce the same situation? You have no gradient in the RVOT, but your RV pressure is high. Anyone? Anyone?
Sir, can you repeat the question, please?
Your RV pressure is high, and you check the pressure in the whole RVOT up to the RPA. There is no obstruction anywhere, but still your RV pressure is high.
Residual VSD, sir.
VSD is
good. There could be, one is a peripheral pulmonary stenosis, or the other one is there could be a residual VSD, or there are collaterals, which is producing pulmonary hypertension. Now we have to differentiate. There's a problem, isn't it? If it's a peripheral pulmonary stenosis, you can't do much as a surgeon. If it's a residual VSD, then you can do something. Okay. Now what will you do? No, before that. How to differentiate between a peripheral pulmonary stenosis and a residual shunt? What will happen to the LA pressure when there is a significant residual shunt?
What is the residual shunting? Left to right or right to left? Left to right. So
left to right, because you relieve the RVOT. Okay. So it will shunt left to right. So what will happen to the LA pressure? LA pressure will increase. Your LA pressure will be high. Suppose there is a peripheral pulmonary stenosis, what will happen to the LA pressure? It will be low. Okay. So if it's low, it's peripheral pulmonary stenosis. You cannot do much as a surgeon because you can go only up to the hilum, and rest of the things you have to image and then plan. Okay. So if it's a peripheral pulmonary stenosis, it's beyond your capability in the theatre. But if the LA pressure is high, you should look for a residual VSD. Anything else can produce high LA pressures? Collaterals. Collaterals. Anything? Anything else?
PDS.
Sir, residual AR is present.
Or AR is rare.
Sir,
please, when you are answering in an examination, tell the common things. Don't go for the extremes. Okay. You don't want to prove to the examiner that you are very bright. You just want to say, prove to the examiner that you are safe and logically thinking. Okay, nothing more. You don't have to prove that you are very good. Okay. So how many aortic stenosis, aortic regurgitation you have seen? No. What could be the other thing? Yesterday I told you the proportion or the level of cyanosis is dependent on the RV outflow obstruction. So if you got a very blue child, how much blood will go to the RV, to the pulmonary artery? Very less blood. So how much blood will come to the left atrium? Very less. How much blood will go to the left ventricle? Less. So there is, tetralogy is a left ventricle is underfilled. It's chronically underfilled. A patient, as they grow older, the obstructions become tighter and less blood comes to the left ventricle. So left ventricle is not used to taking this normal cardiac output. Understand? So it's an underprepared. There also your LA pressure will go up. Okay. But that is a diagnosis by exclusion. What do you have to exclude? You have to exclude a residual shunt and a collateral. Okay. Now how will you exclude a residual shunt? Easiest and simplest is do an echocardiography, TE or epicardial echocardiography. Okay. Suppose you don't have an echocardiography, what will you do? Step up. What do you mean by step up? If you are left a ASD, your RA saturation may be high. Okay. So practically what you do is that you want to make sure that whether your pulmonary artery saturation is high. Okay. When you take a pulmonary artery saturation, if it's less than 85%, you can be rest assured that provided you are on 50% FiO2, if the saturation is less than 85%, very unlikely that there is a shunt. Okay. If it's high, what you do is that you check a step up, not from RA to PA, you take from SVC to PA, especially when you have left a PFO. Understand? So you can decide whether there is a shunt. What is the fallacy for this compared to a pure VSD closure? It will be more accurate in a tetralogy or in a VSD closure? Anybody? Why? He said VSD will be more accurate. Why? What else are we doing in the RV? I think you come here. What else are you doing in the RV? You are resecting so much of muscles. So these muscles will have coronary arteries there. There will be some coronary bleeding into the RVOT. Understand? So that can produce an erroneous step up. So it's not as foolproof or in a VSD or multiple VSD. But still, if you can get a PA saturation less than 85%, you can be rest assured that there is no significant shunt. Understood? See, we surgeons, we have all 4 chambers of the heart in front of us. We have a needle, we have a transducer. Okay, if you have a doubt in echocardiography, what will you do to confirm? You do a cath. You can straight away do a cath. You have access to all chambers. You have access to aorta, you have access to PA, you have RA, LA, LV, or RV. Okay. So you do that. Only thing that you should go systematically and know how to interpret it. Understand? Any doubt?
Baiju, escalating from shunt to total repair.
Sorry?
Concept of shunt to when do you do shunt, when do you do total repair. So the decision.
No, before coming to that, what is the method to take PRV LV? The correct method to take compare the pressures of the right ventricle and the left ventricle. You take a long needle and put it and you go down without hitting the posterior wall, then you will see a higher pressure. You pull back, it will get flattened when it reaches septum. You pull back a little more, it will reach the right ventricle. It will tell you the RV pressure. But practically, we don't want to poke at the end of a long day, we don't want to poke the posterior wall of the LV and then put back there. So we equate the aortic pressure to the LV pressure. So you just check the RV pressure. And you have to rule out a left ventricular outflow tract obstruction when you're doing a DORV or something has got a potential to produce an LV outflow obstruction. Okay, that case you have to check the LV pressure. In a normal tetralogy, you can equate the aortic pressure to the LV pressure. Okay. And sir was telling something about a step up.
Sir, first we'll be off bypass and we'll tell the anesthetist to keep FiO2 at 50%, and then we'll take one sample from the RA and one from the PA, sir. But same time, ideally we would like to take it simultaneously. Yes, sir.
Jayan wanted, what about it? Like, okay, when do you stage a tetralogy? That's what Dr. Jayan wanted to discuss. When do you stage a tetralogy repair? Whether we will do a shunt, whether we will do for total correction.
Age factor is.
See, the philosophy is that to correct it totally as early as possible. Understand why? Because in the first year of life, your lung is still developing. So you want to give a normal flow to the pulmonary artery so that the lung development will be complete by, normally it gets complete only by the end of first year. So during that first year, you want to give that much normal perfusion to the lung so that the lung develops normally. So the philosophy is to correct it as early as possible. Okay, but there are problems associated with neonatal corrections. So, and there are some anatomical factors which will prevent early correction. Can you tell me any of those? Yeah, small pulmonary artery, it's very subjective. The absolute indication will be any correction which needs a conduit. Because you put a very small conduit, you are putting the child at risk of multiple redos. Okay. Then everything else is relative, subjective, depending on your unit's policy. And when you are asked in the exam, you can tell that at what age you will do. Most units in this country will do 3 to 6 months, and many units who are confident of managing complex neonates do early. The advantage of early is that the single stage surgery and there is a better development of the pulmonary artery later on. Understand?
So again, whatever you've seen in your particular institute is the practice, because it will vary from place to place.
You tell what
commonest in this era, in institutes which handle congenital load significant amount would be 3 to 6 months, median weight of around 6 kg. But that might not apply to all of you. So if you've seen shunts as the palliation as the first stage in that weight also, it is as long as you can justify your answers. If you have seen, if you work in a place where BT shunts have gone out of this thing and you treat with ductal stents, that's also fine. But you should know that these are modalities of palliating a shunt as a bridge to total repair. So which may be variable depending on the place you're training. And that is okay as long as you can justify your answers.
So regarding the timing of the surgery, I was not trying to comment on that. Actually, the philosophy behind doing all this pulmonary artery sizes, RPA branch size, LPA branch size, getting Magoon ratio, Nakata index, and all these indices are surrogate markers to predict whether the pulmonary vasculature is well developed or not, that it will take a complete repair, or that's the decision it tries to make. So if there is a doubt that the pulmonary vasculature may not take up a complete repair, that is the decision where we go for a shunt. That I wanted to highlight as the philosophy behind that.
Okay, shall we move ahead? Yesterday, Dr. Bijoy was suggesting me that we should discuss something about the post-operative care.
So now you have come off, inability to come off thing is over. Now your patient has reached the ICU.
We need to rush also. So post-operative.
So what are the common post-operative problems that you anticipate in a tetralogy of fellow? What are the common?
So to understand that,
one person just enumerate the thing.
Can I take a minute before? Okay, you are correcting a tetralogy. How are you changing the physiology in that heart? What change are you going to make to the physiology? So you had a hypertrophic right ventricle which had an easy outlet before. Okay. Now, you assuming that you are putting a transannular patch, the right ventricle is slightly pressure overloaded, not too much, because it can only increase up to the systemic level. So you take that you are taking a hypertrophic ventricle which is pressure overloaded, you are adding an volume overload to that because of the pulmonary regurgitation. Understand? On top of that, if you produce tricuspid regurgitation, you are compounding the problem. Understand? So you are changing a pressure overloaded ventricle to an volume overloaded ventricle suddenly. Okay. Now, will this ventricle tolerate the volume overload or pulmonary regurgitation particular? I'll tell you two scenarios. I've got an ASD with say a moderate pH and a tetralogy. I cut across the annulus. Both are pulmonary regurgitation. Who will tolerate the regurgitation better? Why? Tetralogy, you're right. Why?
Sir, RV is already hypertrophic too. RV is already hypertrophic.
Okay, okay, that's one reason. What else? So, what tetralogy has got, they have got a very normal pulmonary vascular resistance. And they have got a hypertrophic ventricle which has got a high end diastolic pressure. So, the equalization of the pulmonary mean pressure and the RV end diastolic pressure occurs very early. So, the period at which the pulmonary regurgitation happens is very less. Understand? Whereas in an ASDPH if cut over, you got a high pulmonary vascular resistance and a distensible RV. So that may not tolerate it. Okay. So you have to have a low mean pulmonary artery pressure. Now if you leave a distal obstruction like a peripheral stenosis, branch pulmonary artery stenosis, what will it do to the main pulmonary artery pressure? It will increase the main pulmonary artery pressure. So that will worsen the volume overload. Okay. You are producing a pressure overload, leaving a pressure overload there. At the same time, you are increasing the pulmonary regurgitation also. That's why it's all important that you have to clear the whole pathway. Understand? So the physiology changes like that. Now what are Dr. Dibesh says, what are the common problems you see? Before that, can I ask you one question? What is the aim of postoperative management? Not related to tetralogy repair. Any post-operative cardiac surgical patient, what are you trying to achieve? Sentence with them. Anyone? What are you trying to achieve?
Hemodynamic stability.
No, you have a target. You are trying to achieve something when you are managing a post-operative cardiac surgical repair. What is your primary objective? Cardiac output, you are somewhere near, but you are not complete. What we are trying to achieve is cardiac index of 2.2, you are somewhere close, but what we are trying to achieve is to have adequate oxygen delivery to the organ systems. Okay, this acts, the adequate oxygen delivery has two components. One is delivery, that is your cardiac output, and there is an element of oxygenation as well. Unless the blood is oxygenated, you can't deliver oxygen. Okay, so that is applicable to every cardiac surgical patient. Okay, your aim of postoperative management is adequate oxygen delivery. Okay, now come to the problem specific. You don't need to third me, okay? I don't want to walk to Trivandrum.
Sir, postoperatively, sir, arrhythmia is common. Second is, sir, RV dysfunction.
You told arrhythmia. What arrhythmia is very common in tetralogy?
Right, RBPV, sir.
Junctional ectopic tachycardia. Can you describe?
Why is it so hot? Why are we talking about junctional? Because it originates at the outflow tract. The most common origin of junctional ectopic tachycardia is around the outflow tract, and because we give right ventriculotomy incision for repair of TOC, these ectopics give higher dischargeability.
So why are you so worried about what it does to the patient?
So it decreases filling of the right ventricle, and the arrhythmia can degenerate into ventricular arrhythmia.
So what is it doing to your cardiac output?
It will decrease, sir.
Why?
Okay, okay.
The diastolic duration is reduced, so the
So first question,
end-diastolic volume
how
is
will you
reduced.
identify junctional ectopic tachycardia? No, the other common arrhythmia in a tetralogy post situation when you are on anotropy is sinus tachycardia. Okay, so, or you can have an atrial tachycardia, or atrial fibrillation is very rare in children. So what is unique about junctional ectopic tachycardia? When you see it on the monitor, you say that this is junctional ectopic tachycardia. What are the unique features? One thing, it's usually fast, it's a narrow complex, it's regular. Understand? If you've got an irregular thing, it's not junctional ectopic tachycardia. You've got
CVP trace would be.
And you got a broad complex, it's not junctional ectopic tachycardia. It has to be narrow complex, it has to be regular, and it has to be, usually it's fast. Understand? And if you have a doubt, what will you do? You can take an ECG. You can take an ECG, but ECG may not show the P waves because especially when it's fast, it's very difficult to differentiate when your rate is fast unless you slow down the paper. You can slow down only to one speed. Okay. If it's not clear, what will you do? No, anything else?
Something before.
Something else in a post-operative period, you have some more access to the heart to record an ECG. Take an atrial wire ECG. Take an atrial wire ECG. What will it show? In a junctional tachycardia and a sinus tachycardia. How will you differentiate from atrial wire? You will see a retrograde P wave. You will see a retrograde P wave which follows the QRS. Retrograde P wave. Okay. And your CVP, Dr. Debeshia said, your CVP also will give you a clue. Your CVP.
Why do we lose cardiac output or reduce cardiac output in a jet?
Sir, in jet, because of the tachycardia, the diastolic duration
Okay,
is
so
reduced.
one is tachycardia, which would be there in sinus tachycardia also, beyond a certain extent, inadequate filling. What exactly is happening when you are having jet? What are you losing? You're losing the atrial kick because see, it's not a heart block, but it is a ventricular, it's a dissociation still. So that is why you are losing your cardiac output. So that is why all the treatment modalities for jet would actually aim to reduce the heart rate because then you have means to treat it. So what are the other arrhythmias that you see in a tetralogy?
So right bundle branch block can be seen.
So very commonly seen,
Right bundle
usually
branch.
innocuous. You could also have, you can come back with a heart block from the theatre itself.
Yes, a
That's
complete
also
heart block,
form of-
ventricular arrhythmias can be seen, sir.
Okay, if you got a complete heart block post-tetralogy repair, what will you do? What pacing? Dual chamber for the reason what Dr. Debeshia is telling. Because these ventricles are hypertrophic, you are dependent so much on the atrial kick to provide the filling. So you put a DDD mode. What else will you specifically set in the DDD mode? AV delay. Or you keep, for the particular rate, there is a maximum AV delay what can be kept. You try to keep on the higher side. Why do you want to keep on the higher side? It gives more time for the ventricle to fill. Understand? Okay.
There you are having an AV dissociation. In jet, you are having a VA dissociation. Effectively, any dissociation takes your atrial contribution out. In smaller children, that amounts to a significant amount of loss of cardiac output.
So how do you treat jet? One of the difficult arrhythmias to treat. No, I'll tell you the basic principles. One thing is that you have to keep the ventricle adequately filled, except a higher CVP. Second is that you try to reduce the inotropes will worsen your jet. You try to reduce the inotropes as much as possible, especially you are on adrenaline or dopamine. You can try to maintain the hemodynamics with milrinone or noradrenaline or vasopressin. Okay. Then next thing is that you try to cool the patient. Obviously for any arrhythmia, you should correct the electrolytes and whatever is correctable. And then you try to cool down the patient. Let the patient temperature drift to 34, 34.5, whatever you feel is safe, and reduce, and then Agitation, take out agitation. Take out agitation. Patient should not move around. Sedate, paralyze, whatever you want to do. Next, if possible, your idea is to get AV synchrony. If possible, you can pace AV sequentially, even if it means you have to pace at 150. If possible, you try to pace dual mode.
For that, your heart rate has to reduce so that you can override.
Understand? So you can accept a higher heart rate for the sake of AV synchrony. Okay. And next, pharmacological? Amiodarone is ivabradine can work. Ivabradine can work. There is evidence that ivabradine works, but you add ivabradine to amiodarone, you will have more higher chance of getting back to sinus rhythm. But in exam, your drug of choice is amiodarone. How much will you give? 5 mg per kg loading dose and 10 mg per kg over the next 24 hours. Easy to remember. Okay. Okay, that's about the arrhythmia. Now, sir, please. Yeah, the bench is asked and somebody he answered.
Sir, the origin of junction ectopic tachycardia is at maximum at the outflow tract, and because we give a right ventriculotomy incision.
Okay, we'll just leave the arrhythmias there and just move on to the next thing. Next common thing, right ventricular dysfunction. Why do you get right ventricular dysfunction? For the reasons I told. And if you do excessive resection of the right ventricle, then you can have right ventricular dysfunction. That's why I said too low RV pressure is also not desirable. You don't have to achieve that normal RV pressure, 1/3 of systemic pressure. Okay, so you want the RV to be little thick so that it doesn't balloon with the regurgitation. Understand? So how do you identify RV dysfunction in post-operative period? Obviously they will have low desaturation. Yes, it can happen only when you have got a PFO left. And most younger children, especially when they are less than 6 months, we leave a PFO. The idea is to, when there is an RV dysfunction, to maintain some LV filling. Okay, so it maintains the LV filling at the expense of saturation. Okay, you may be wondering how much blood can go through a PFO and maintain LV filling, but you should remember all cardiac surgery has come from azygous flow principle. You know what it is? When you occlude the SVC and IVC and let the azygous come, it can still sustain the vital organ function for 30 minutes. Okay, so a phase of transient RV dysfunction, the blood coming across the PFO can still maintain some sort of organ perfusion. Okay, that's the logic of leaving PFO. But desaturation is not the first thing.
CBB?
Yeah, the thing that one other target what we need to maintain, we need to remember is that the ventricle is thick and it will work at a higher filling pressure. So your target filling pressure, especially when you have a when you have a transannular patch, has to be in 2 digits. There is now even though I said there is no target for CVP. Your idea is to maintain the cardiac output, maintain the oxygenation, and whatever CVP which gives you that, what are the lowest CVP which gives good adequate oxygen delivery is your target. But when the oxygen delivery is less, cardiac output is less, you can increase the CVP to much higher values. Understand? Okay. So, okay. This hospital. See, it was actually a slip of tongue to tell that there is a target CVP. I was trying to tell you, there is no target CVP for any patient. Your idea is to get the maximum oxygen delivery. Take it as a cardiac output. Whatever is the lowest filling pressure which gives you the adequate cardiac output is your target. Understand? Suppose patient is going into low cardiac output, this ventricle is hypertrophic, so you can accept a higher filling. You can fill more because the ventricle is thick. Understand? So usual CVP for a tetralogy, especially young tetralogy, is somewhere around 10 to 14 when you have got a transannular patch. Understand? But if you get good cardiac output at 8, you'll be happy. You'll be happy.
Now
you
that
don't
we're
have to
talking
chase
about
it.
cardiac output,
Understand?
how do you clinically say that this patient is in low cardiac? Clinically, based on what you're examining, and then based on what you see on the, beyond just clinical examination. Cold peripheries. Okay, delayed capillary filling.
Weak distal pulses.
Weak distal pulses or absent distal pulses.
Tachycardia.
Tachycardia.
Hypotension.
Lower mean arterial pressure. Higher filling pressures. And
Decreased
something
urine
to do
output.
with the core temperature?
More than 4 degrees Celsius core to periphery gradient.
So that's again, so very high core temperature is a marker of low cardiac output state. So clinically you're suspecting that this patient is in. So what would you see in your, say, blood gases?
Increased base deficit, metabolic acidosis, and a higher lactate level.
Higher lactate level. Okay. And do you have any other form of, beyond ABG, would you want to see anything else?
VO2 max, mixed venous oxygen gas.
Okay. So that's again a very sensitive.
See, that is the single most important parameter which tells you that your oxygen delivery is adequate. So mixed venous means you have to take a pulmonary artery saturation, but it's not always possible. So you take a mid SVC saturation. All the patients will have a neckline. So why it is most accurate? Because it's in dynamic equilibrium with the oxygen delivery. If you deliver less oxygen, your extraction will be more. But other parameters like metabolic acidosis or lactates, there is a lag period. Lactate will tell you what was your oxygen delivery 6 hours before or 4 hours before. But mixed venous saturation will tell you what is your oxygen delivery at the moment. Okay, we are deviating. So right ventricular dysfunction, it can be a systolic dysfunction, can be a diastolic dysfunction. We will present as a low cardiac output with high CVP, hepatomegaly, ascites, and effusions in a post-op tetralogy usually. Okay. So why does right ventricular dysfunction produce effusion? I used to wonder. Why should it produce? Usually the left ventricular dysfunction should have back pressure and effusion. Why does the right ventricular dysfunction produce effusion? Have anyone thought about it?
Sir,
Get up and say aloud. No, your right ventricle is dysfunctional. It's not pumping as well as to the lung. It's not pumping well, isn't it? And then why should it produce pleural effusion?
sir, etiology can be similar to hepatic hydrothorax where the fluid passes through the
I beg you, don't complicate me. Simple. This cardiac surgery is very simple. I was telling you the other day, just fluid dynamics. Okay, for that you should know what is there fluid in the pleura normally? There. Where is that fluid going? In the lymphatics. It's going to lymphatics. There. Okay, it's because the lymphatics train to the venous. It's into the jugular vein, the subclavian jugular junction. Okay, so your CVP is high, your lymphatic pressure is high. So your pleural fluid which is occurring normally cannot clear. Okay, that's what's happening in Fontaine's. They're asking me to leave. And now you can be the examiner for 5 minutes. You can be you have any doubt, you can ask.
Another terminology you should be familiar with is somebody just may ask you what is restrictive RV physiology. So it's like, it's a diastolic dysfunction part, but you have to be aware of what exactly is a restrictive RV physiology in a post-op petrology. So that is another question that it may lead. It's nothing, it's just a very sophisticated term for a diastolic dysfunction, but restricted RV physiology is as a term you should be familiar with.
Thank you, sir.
Sir has asked me a question, how to manage RV dysfunction. So how do you manage RV dysfunction? Maintain enough preload.
Reducing the afterload.
Like any dysfunction, reduce the afterload. How can you reduce the RV afterload?
Pulmonary vasodilators?
No, that's wrong concept. I told you tetralogy is a very low pulmonary vascular resistance to start with. Okay, now what we can manipulate the pulmonary vascular resistance is by manipulating your ventilation. Okay, So you take away, like you ventilate a fontan. Low tidal volume, low pressure, so that your RB afterload is lowest. Understand? So you maintain the preload, reduce the afterload, and extubate whenever it's clinically appropriate. There, the RV will function best when they are on spontaneous ventilation, because the negative intrathoracic pressure will aid the RV pumping. Understand? It will reduce the RV afterload and ionotropes selectively. Okay. And milrinone is the ionotrope of our choice, and there is something called diastolic dysfunction. And how do you identify diastolic dysfunction? By echocardiography, one single DAPC is for systolic dysfunction. Anyway, thank you so much, and all the best to all of you.
Thank you. So I think there is a, before we break for a short, I think I'll invite Dr. Bijay Kuti on stage to have a quick thank you note.
Can I have a minute? Yesterday, after the dinner, somebody asked me, why should I be a congenital heart surgeon? I want to answer to all of you, because it's an advertisement for congenital heart surgery. You just have to see the natural history of transposition. If you don't operate a child on time, only 5% will see the first birthday. And if you do an arterial switch on time, long-term survival is 90 to 95%. So from 5% survival, you are increasing to 95%. You tell me any other place in modern medicine where you can change the natural history this much. You tell me. Okay, that's how you should take up congenital heart.
Thank you. Dr. Bijay.
We will have just short 5 minutes. Beju, I am also coming with your 2:30, so don't worry. Just 5 minutes. First of all, at the onset, let me tell you, when we were planning this IPREP, the EC felt that all of us the students should get a chance to have an on-site program. So at the onset, let's have a standing ovation for Dr. Satyajit Bose for taking the onus to prepare this. It's indeed an amazing thing. So every president, everyone who becomes a president of IACTS tries to set a legacy. I hope that this on-site IPREP, which has been done on such a big scale here, will happen an yearly event. Once again, let's give him a big clap. So there are always many people behind the event who try to make it a success. For us, Srikanth has been the go-to person. He deserves a big clap. His team, ably supported by Dr. Rahul and many other people in the team, and many hidden faces right down from the reception to the drivers who came to pick us up, to everybody. So let's give them a big hand morning. A big thanks to the EC of the IACTS for agreeing to give the travel grant. And one more very important thing, any such program cannot be a success without so many HODs who came here, from AIMS to Jagdeva to everybody. And Dr. Vinita for doing the fantastic quiz, to everybody. Everybody has put that, nobody refused and said no. Now there is one more very important thing I want to tell you. This has to be an yearly event. Each one of you must write to the Secretary IACTS about your experience and saying that, sir, we want this next year. Because if we don't have enough sponsors, Dr. Bose was able to generate sponsors, then the IACTS should take it upon their owners to have this program. We can only do it if you all give this feedback. So your job is to become associate members, your job is to give feedback. Only then this will happen next year. Otherwise, it's in your hands. It's not only in our hands, okay? And last not but the least, a big thank you to all the sponsors whose name you see here. I mean, without that, it can never be a success. So a big thanks to all the sponsors. So thank you all for coming. Enjoy your rest of your stay here and all the best for your exams. We want more and more cardiac surgeons. More will be the tribe. We'll all grow together. That's the point. Thank you all once again.
Thank you. Now there is a short break while they organize this room for the wet lab. So we have saved the best for the last. You're going to learn it from the master of masters. So Dr. Bose and Dr. Shrup Chatterjee will be the main mentors. You will be getting tables. So you can have a very quick break, reassemble here while they set up for the wet lab. And I hope you enjoy the rest of your part. And just make sure there are no objects left on the table so that it will be easy for the people who organize the wet lab workstation. Thank you. I think the lunch is just after the wet lab. After the wet lab, like more or less.